Hello everyone, a very good evening to all of you. So I welcome you all for today's session. I am Dr. Priyanka Sachdev here. I hope I'm clearly visible, audible to you guys. Yes or no? So kindly write down in the comment box if I'm clearly visible, audible, everything is good to go. Can we start the session? Yes, I guess I'm clearly visible. Yes. So I welcome you all for today's session. So today we all are gathered here to study contraception at one place, at one shot. So I don't know whatever exam you are preparing for. Maybe you are a third prof university, you are preparing for your third prof university exam and you are preparing the contraception topic from community medicine. Or maybe you are a final year MBBS student and you are preparing it from the gynecology for your university exam. Or maybe you are an intern, post-intern and you are preparing it for your any of the competitive exam, that is NEET PG, FMGE, INI, or PLAB, USMLE, whatever. But I can assure you the next 2-3 hours are going to be super beneficial for you. So at the end of the session, you will become super confident in the topic, and whatever exam you are targeting for, you will crack that very easily. All the questions coming from contraception and contraceptive devices. So without wasting any further time, I guess I must start. Can I start? So let's start it. So let's start the topic, contraception. So I guess you can see my screen. Yes? So let's start the topic, contraception. Let's start it. Okay. So before starting the contraception, let me give you a little bit overview. So what is fertility? What do you mean by fertility? Fertility is actual bearing of the children. A couple is having how many children? That is the fertility of that couple, fertility of that human being. So now in a couple, there is a husband, there is a wife. I mean, there is a male, there is a female. The male is fertile from puberty onwards till death. But the fertility of female depends on the age of the female. Now, in the entire life of a female, we are talking about a female. So see, I'm drawing the diagram of a life of a female. This is the birth of a female and this is the death of female. Okay, birth and death of a female. We are seeing the female life. So at the age of nearly 15 years, 13 to 15 years, there is menarche. What is menarche? Menarche is start of menstruation. I mean, the ovaries become active and ovaries start secreting ova. I mean, the female is fertile from now onwards. And at the age of 45 to 50 years, let's say 45, it can be 45 to 50 variable. There is menopause. What do you mean by menopause? Menopause means stoppage of menstruation. I mean, the ovaries become atrophied and ova release will not be there from now onwards. So we can say, we know for fertility, the ova is required. So the fertile period in the life of a female is for 30 years. That is 15 to 45. Before 15, the female is non-fertile, and after 45, the female is non-fertile. So the fertility of a female is for 30 years. 30 years. So that depends on the female. You got my point? So you can see it here. from 15 to 45, the female is fertile and the fertility depends on the couple, in the couple of the life of the female partner, in the age it is. So that is the thing. Now let's come on the topic family planning. What is family planning? Family planning, it is a procedure in which a couple plans when they want to have children using various birth control methods and techniques, that is known as contraception, and today we are going to study that. So in India, the logo for family planning is this. You can see, you can understand the logo. There is a male partner, female partner, there is a kid. So this logo is for family planning. Okay, so can we start? So whatever subscription you people are looking for, kindly in the end I will give you a number. You can text on that number. Currently we can concentrate here on this topic. So can we continue? Let me open the chat. Give me a minute. Give me a minute. Yes. Okay, I can see the chat. Okay. So can we go ahead? Okay. So let's come on eligible couples. So we have seen what is family planning. Now coming on the eligible couple. What is eligible couple? I told you, in a couple, in a husband and wife, the male and the female fertility is from 15 to 35, 15 to 65, 15 to 45 years. That is for 30 years. So it depends on the age of the female. Got it? So any couple in which the wife is in this age group, that couple is known as eligible couple, because only that couple can reproduce. Now imagine a couple in which the wife is younger than 15 years, that couple cannot reproduce. Imagine a couple in which the wife is older than 45 or 50 years, that couple cannot reproduce. So for family planning, we target the eligible couple. In an eligible couple, the wife is in this age group, that is 15 to 45. So any couple in which the wife, the female partner, is 15 to 45 years of age, so female partner in this age group, that couple is known as eligible couple, because that is the need of the family planning services. We have to offer family planning services to such couples. So in India, the family planning, the eligible couple register for family planning services is maintained by the female health worker at the sub-center. So that is, in India, we maintain at sub-center. Now, I will tell you what are the contraceptive methods we use. Now, I want to tell you what is couple protection rate. What do you mean by couple protection rate? CPR. What is couple protection rate? Out of the total eligible couples, how many couples? Out of the total, now you understood what is eligible couple? So out of the total eligible couples, what percentage of eligible couples are using contraception? One of the 4 important contraceptive services at the time of the intercourse. So that is known as couple protection rate. Couple protection rate. So we have to make couple protection rate at least 60%, so that it will be a balance. It will be a balance. That is, NRR will be 1. I will explain you what is NRR. So we have to make it at least 60% of the couples should use contraception at the time of the intercourse, and that will make CPR as 1. That is couple protection rate. So what is couple protection rate? It is the total number of eligible couple which are using any of the 4 methods of the contraception out of the total eligible couples into 100. It is in terms of percentage. So what are the 4 approved methods by Government of India? The 4 approved contraceptive methods which we use in this definition. Number 1, male condom. Number 2, OCP, oral contraceptive pill. Number 3, intrauterine devices. And number 4, sterilization, the terminal methods, the sterilization. So one of the 4 methods. So out of the total eligible couples, total eligible couple, who's the eligible couple? In which the wife is in reproductive age group. How many of them? How many percent of them, eligible couples, are using the contraception? One of the 4 contraception, you know which 4. So either male condoms or OCPs or IUCD or sterilization. Any of the 4, any one of the 4 into 100. So that is known as couple protection rate. So I guess you got this definition. Now after this definition, let's start the contraception. Let's start the various methods of contraception. Can we start? Give me a thumbs up if you got everything till now. So let's start it. Let's start the various contraception methods, contraceptive devices or methods available, and we will see the detail of each of them. Okay. Now listen, what is the ideal contraceptive? What is the definition of an ideal? There are many methods available. So we have to offer all of these to the couple, and we have to select which is the best for which couple. So we have to see the advantages, disadvantages, side effects, adverse effects, uses of each of them, and we have to understand if any couple is coming to you as a doctor and they want you to advise them what is the best contraception method for them. So you have to tell them the pros and cons of each of them, the advantages and disadvantages of each of them. Then only the couple can decide what is the best for them. Okay, so what is the ideal contraceptive? Ideal contraceptive should be safe, should be effective, should be inexpensive, should be reversible, should be simple to use. It should be independent of the coitus. It should be long lasting. It should require minimal medical supervision. So such a contraceptive is the ideal contraceptive, but there is no ideal contraceptive available. All of the contraceptive have some advantages, some disadvantages. So we will see the details of all of them one by one. Now there are two types of couples. Imagine there is a couple. Imagine there is one more couple. This couple already have 2 children. They do not want more children. So what contraceptive services you will provide them? So we will provide them terminal services. That is sterilization. We will offer them sterilization because they have already completed their family. They already have 2 children or whatever children, but they do not want to expand their family. So we will offer them sterilization. That is terminal methods. But there is a couple who don't have the children or who have some children, but in future they want to extend their family, expand their family. So we will provide them spacing methods. So spacing methods are temporary. That is, they temporarily suppress the fertility of the individual, but sterilization permanently suppress the fertility of the individual. So that is 2 types of contraceptive methods are available. First of all, we have to understand the classification. Okay, so 2 types of contraceptive methods are available. The spacing methods, these are temporary. They temporarily suppress the fertility of the individual, and terminal methods are permanent. So we offer terminal methods only to the couples who have already completed their family. So in the terminal methods, we have 2 types of sterilization, the male sterilization, female sterilization, that is vasectomy, tubectomy. We will see the details in the end. Before that, I would like to tell you the details of the spacing methods. The spacing methods are the temporary methods. So there are 4 types of spacing methods. The natural methods. So there are 7 types of natural methods. We will discuss all of them. The second is the barrier method, which is the most commonly used method in India as well as in the world. So the various types of barrier methods we will discuss one by one. The third is the IUCD, intrauterine devices, contraceptive devices. And the fourth is hormonal, in which oral pills are also there and injectables are also there. So one by one, we will see all the spacing methods. So can we start? So let's start the spacing methods. So in this sequence only, we are going to discuss all about the contraceptive devices one by one. Okay, so any confusion, any doubt till now in this topic? If you have, please write down in the chat box. If you have any doubt till now, please write down in the chat box. So can we continue with the spacing methods? So let's start with the spacing methods of the contraception. Okay, that is the temporary methods. So the first method here is the natural family planning method. So natural family planning method, there are 7 natural family planning methods. We will discuss one by one all of them. You get many MCQs on these methods, the natural methods. So let's start the natural methods. There are 7 natural methods as I told you. So one by one we will see the details. What's the basis of all these methods? Why they are called as natural methods? So for understanding the natural methods, you have to understand the menstrual cycle of a female. So when the female is ovulating, at that time the sexual intercourse has to be avoided. So that is the basis of the natural methods. So how we come to know that in the entire menstrual cycle when the female is ovulating, so we can judge it based on the calendar or various symptoms in the female body. So that is the basis of all these 7 methods, the natural methods. So in a menstrual cycle of a normal female, in a normal menstrual cycle, it is of 28 days. Menstruation is a physiological phenomenon in the female. So we start from day 1 till day 28. So for the first 5 days, there is flow. The bleeding is there. The menstruation is there for the first 5 days. So in a 28-day cycle, at 14 day, there is ovulation. But the cycles are not always regular in all the females. So in some females, it can be more than 28. In some females, it can be less than, and every month it can be different. Okay, so it is not necessary that every month it is ideal 28-day cycle and the ovulation takes place at the day 14. It is not always ideal. So it depends from female to female and the menstrual cycle length of the female. So this is the basis of the natural methods of contraception. You are getting it? So can we go ahead? So natural methods, the first method in the natural method, one by one we will discuss all 7. So let's start with the first method. The first method is known as calendar method, also known as rhythm method, also known as safe period. What do you mean by that? What do you mean by calendar method, rhythm method, or safe period? What do you mean by that? Now you can see here we have drawn the ideal menstrual cycle of 28 days. Now this method is discovered by a person known as Ogino, and it is known as calendar method because it depends on the length of the menstrual cycle of the female. So here the formula is formula is what is the fertile period? Fertile matlab unsafe, during which the sexual intercourse is not allowed to the couple. So that is unsafe period, the fertile period. So whatever, now just there is a female to whom we consider the ideal menstrual cycle is 28 days every month. There are very few females in which there is everything is ideal every month. Now, most of the females have irregular cycles, or it is not of 28 days. If it is or regular also, it is not necessary. It is always 28 days. It may be more than that. Some females have every 30 days, every 35 days. Some have every 20 days, 25 days, whatever. So here, just suppose it is 28 days we consider. So the formula says the shortest cycle minus 18 to longest cycle minus 10. Here, shortest and longest, both I am considering as 28. So 28 minus 18 to 28 minus 10. 28 minus 18 is 10 days. From 10th day of the menstrual cycle to 18th day of the menstrual cycle. You can see it here. 10th day to 18th day. This is fertile period, that is unsafe period, during which sexual intercourse is not allowed. Now, sexual intercourse is allowed after this or before this. Now, before this, before 10 days, during the first 5 days, the female is menstruating. So again, sexual intercourse is not allowed. So from day 6 to day 9, day 10 onwards to day 18, it is not allowed. From day 18 onwards till next menstruation, it is allowed. So that is the safe period. So this method is known as calendar method. How many of you got it? So what is the formula? You have to learn the formula. What is the formula? Formula is fertile period. What is fertile period? So fertile period of a couple depends on the length of the menstrual cycle of the female partner of that couple. Okay. Now the female is menstruating because the female is a reproductive age group. So the female may have variability in the menstruation. So we have to ask the female. Just suppose I am a doctor and a couple is coming to me taking contraceptive advice and they want natural method. They do not want OCP, barrier method or any other method. They want the natural method. So I will ask the female partner, I will ask the wife that what is your shortest cycle till now? Shortest, you may have many menstrual cycles till now. What is your shortest cycle? And what is your longest cycle? So we will ask that and we will calculate that and we will give that to the couple. Okay. So the formula is shortest cycle minus 18 to longest cycle minus 10. So this is unsafe period. You calculate. Just suppose the female is having shortest cycle as short as 25 days and longest is as long as 35 days. So sometimes she have menstruation 25 days as short as that and sometimes she have as long as 35 days. It is not ideal in that female. So here shortest minus 18 means 25 minus 18 to longest minus 10. That is 35 minus 10. So can you do the calculations for me, please? 18, I guess it is day 7 onwards to day 25. So it is a long fertile period, that is unsafe period. So the menstruation is sexual intercourse is allowed either before that or after that. Before that, remember the first 5 days is menstrual cycle. So again, so it is not allowed. So technically the sexual intercourse is allowed only after day 25. So there is a long period of fertility or unsafe period. So greater is the variability in the menstrual cycle, that unsafe period will be more. And if it is a regular, the unsafe period will be less. So that is the thing. So that is the calendar method. So that is the that's what I have repeated. So Tara, you got it? So that is the calendar method. Now the formula. So again, the question is going to come on formula. What is the formula? Shortest minus 18 to longest minus 18. If it is regular, the shortest and longest is same. But if it is irregular, you have to put the shortest as well as longest. Got my point? Let's take one more example. The shortest cycle is 26 and the longest cycle is 31. You can do it. So 26 minus 18 to 31 minus 10. Shortest minus 18, longest minus 10. Just do that. It's as simple as that. Whatever is the answer, that is unsafe period during which sexual intercourse is not allowed. So either before that or after that, the sexual intercourse is allowed. You got it? So what are the drawbacks of this method? In irregular cycles, sometimes it becomes very difficult to calculate all this. For this, educated couples are required. The couple should understand the menstrual cycle. The female partner should understand and they should be able to follow that. And this is known as programmed sex, because here the sexual intercourse is allowed only in the safe period, either before or after, not during the unsafe period. And it is not useful in postnatal period and failure rate is very high. Failure rate is very high. So these are the drawbacks. So we have seen the first one, that is calendar method. How many of you got it? Give me a thumbs up if you got it. How many of you got it? How understand short or long cycle? So Sutara, the longest cycle and shortest cycle only the female can tell. So every female have menstruation every month. So the female, now just suppose a couple is coming to you. You are a doctor, couple is coming to you taking contraceptive advice and they want the natural method. They want the calendar method. So ask the female partner, till now you have many menstrual cycles. So what is your shortest cycle till date? Tell that. And what is your longest cycle till date? If she's saying, no doctor, I'm having very regular menstruation and every 28 day only or every 30 day only I'm having the menstruation, it's not irregular, every 30 day I'm having. So shortest is also 30 and longest is also 30 in that case. But there may be a female who is saying, no, sometime I have as short as 20 days, sometime I have as long as 35 days. So consider the shortest as 20 and longest as 35. This is how only that female can tell you. So what is the shortest and the longest cycle for that female? And if it is regular, there is no shortest, longest, it is one only, the same only. I hope you got it. Everyone got it. So this is how, being a doctor, you have to calculate the fertile period, unsafe and safe period for particular couple, and you have to calculate and give it to them, because they are not the medical, no, so they are the persons who are coming to you taking the advice. So you have to calculate and give it to them, but you have to tell them the failure rate is very high. All the natural methods have very high failure rate. Okay, so we are done with the safe period rhythm method or calendar method. Coming on the second type of natural method. The second type is basal body temperature, BBT, basal body temperature of the female partner. What do you mean by that? So we take a very accurate thermometer. The thermometer should be able to pick up the temperature change as small as 0.1 degree Celsius. So it should be very accurate thermometer, and we give it to the female. And we ask the female to measure the body temperature daily before she come out of the bed in the morning. The first thing in the morning she should do. So in the morning when the female partner is waking up every day, so every day she should measure her temperature. So what is the menstrual cycle? You must understand the menstrual cycle. This is a normal menstrual cycle, ideal menstrual cycle in a female. That is 28 days. You can see here it is starting from day 1 and day 28. If it is a 28-day cycle, on day 14, the ovulation takes place. The ovulation takes place at day 14. So at day 14, what happens? The Graafian follicle is rupturing in the ovary. So the Graafian follicle is rupturing, so ova is coming out. When the Graafian follicle rupture, the ova come out, the corpus luteum is formed, and corpus luteum starts secreting progesterone. So you can see the green line here. Till now the progesterone was very low, and the day it ruptures, I mean the day ovulation occurs, it start rising. It start rising and it become peak later on in the later half of the cycle. So before ovulation, estrogen is maximum, and after ovulation, progesterone become maximum. Progesterone rises the day ovulation occur, and progesterone increases body temperature by 0.1 to 0.2 degrees Celsius. It is not very high, the female is feeling the fever. No. It is hardly, very small rise. It is 0.3 to 0.5 degrees Celsius. It's very small rise. That is caused by progesterone. So the day the female ovulate, at that day, she may have a temperature little bit higher than the regular temperature. So she may notice the change only if she is measuring the temperature daily at the same time with the same thermometer. So daily the female is measuring the temperature with the same thermometer, the first thing she is doing in the morning. So on the day of the ovulation, she will come to know that today the temperature is little bit higher than the usual, that is 0.3 to 0.5 degrees Celsius. So today maybe I have ovulated. So the female will come to know that. So this is how the female can judge that today she has ovulated. So she must avoid the sexual intercourse in the entire this period, because you never know at that, because here the temperature will rise after ovulation. It is not before ovulation. Once the ovulation already occurred, then the temperature is rise. So here the complete this period, the sexual intercourse should be avoided. And after temperature rise also, for the next 3 days also it should be avoided. So ova get destroyed after the 3 days, and after that it is the safe period. So this is basal body temperature. How many of you got it? How many of you got it? Say yes now. How many of you got it? People respond, say something. So it is rise in basal body temperature just before the ovulation or at the time of ovulation, which is caused by the progesterone. So female has to monitor it daily before she come out of the bed with a thermometer. If she is doing it daily, then only she will be able to pick the change. That it's a very minute change. So that is basal body temperature. Again, so you can see what are the drawbacks. So it is reliable only if the intercourse is restricted after ovulation. Before ovulation, before ovulation it cannot be done, because the temperature is rising once the ova is released. Then only the temperature rises. Before that, temperature is not rising. And abstinence is necessary for entire pre-ovulatory phase. So that is the drawback, the biggest drawback here. So we are done with the 2 methods till now. Out of the 7 natural methods, 2 are done. We have seen the calendar method, safe period, rhythm method, and we have already seen BBT, basal body temperature. So coming on the third natural method. Can I come on the third natural method? So the third natural method is cervical mucus method or billing method or ovulation method. What do you mean by that? Now you have to understand a principle here. So all the females have cervical secretion. So the consistency of that cervical secretion, based on the consistency of cervical secretion, the ovulation will be predicted by the female partner in the couple. And when the ovulation is taking place, at that time, the sexual intercourse is avoided. So that is the third method, the billing method. Let me tell you. So here the principle is that at the time of ovulation, you can see the cervical mucus become highly slippery, profuse, and it can make a string. So if it is taken on a finger and a string is formed, it will form a string. So it will happen only when the ovulation is taking place. So at other days of the ovulation, you can see here. So here you can see the cycle. It is starting from day 1 and it is a 28-day cycle. You can understand here. No, it is starting from here. This is day 1. This is 28 day. So please see the 28-day cycle. So for the first 5 days, there is bleeding. Okay. For the first 5 days, there is bleeding. After bleeding, the cervical secretion is not there. It's totally dry. It's totally dry. Then after that, it start become tacky, cloudy. And at day 14, it become completely slippery. Completely slippery. It will remain slippery for 2 to 3 days. Whenever the ova is surviving. And after that, again, it become cloudy and tacky. So what do you mean by cloudy and tacky? This is tacky. It is not forming a string. It is not forming a string. Okay. Here, this one is slippery. So it will become slippery under the effect of the estrogen. Under the effect of the progesterone, it will become tacky. So got it? So the female partner, how it is judged? Female partner has to distinguish the various types of the mucus. So you have, being a doctor, if a couple is coming to you and they want the natural method of contraception, so you can explain this method also, and you have to show the images to the female partner so that she can understand the various type of mucus, the various type of consistency of the cervical secretion, and she should be willing to wipe inside the vagina daily to see the quantity and character of the mucus. Then only she can distinguish the various types, and then only she would come to know that the day when she is having a slippery mucus, the day she is ovulating. So this is so at ovulation, the cervical mucus become watery, clear, slippery. It's like an egg white. Have you seen a raw egg? Have you tried to hatch a raw egg? So there is a yellow portion and there is a white portion. The white portion is the slippery. It is string. It is the same consistency. So you can consider you can explain the female in that way. So have you seen an egg? Have you hatched the raw egg? Not the yellow portion, but the white portion. Have you tried to do like this? So it is slippery, watery, profuse. So the day the cervical mucus is like that consistency, that day the female is ovulating. And that day, and after 2-3 days after that also, the sexual intercourse should be avoided. After ovulation, it will become lessen in quantity and gradually again it will become dry. How many of you got it? How many of you got it? So that is the thing. So this is cervical method. The cervical method, or known as billing method. So what we have learned, whenever the ovulation taking place, at that time, the cervical mucus become like this, like the egg white, it is slippery, profuse and string-like. It will make a string. Other days, it will not make a string. Here, the female is trying to make a string, but you can see it is tacky. This one is tacky. It is not making a string. And here you can see it is profuse, slippery, making a string. I hope you got it. Say yes if you got it. Yes. So that is the thing. So that is the cervical method. So intercourse is considered safe during the dry days, not during the when the cervical mucus is sticky or profuse. It requires very high degree of motivation because the female partner have to wipe up the vaginal secretion, the cervical secretion daily after menstruation, and she has to see the consistency, understand the consistency. So a very high degree of motivation is required. So we have seen 3 methods till now. So out of the 7 methods of contraception, the natural methods of contraception we are discussing right now, we have discussed 3. The first I told you, the calendar method, which depends on the length of menstrual cycle of the female partner, that is the wife. So the formula is shortest cycle minus 18 to longest cycle minus 10. This is unsafe period. This is fertile period of that couple. During this period, the couple should not perform sexual intercourse. Otherwise, they can conceive. So this is the red signal. Okay, so this is the sexual intercourse is highly prohibited during this period. So sexual intercourse is allowed either before that or after that. We have taken the example of 28-day cycle. Just suppose there is a lady who is having menstruation every 28 days. There is no irregularity. So we will consider shortest also 28 and longest also 28. So 28 minus 18 is 10 and 28 minus 10 is 18. So during 10th day to 18th day, the sexual intercourse cannot be performed because we assume the ovulation take place at 14th day. So 4 days before that to 4 days after that to take a margin. The sexual intercourse is allowed before 10th day But the first 5 days is menstruation, you cannot forget that. So from day 6 onwards till day 9, and it is allowed after day 18 till the next menstrual cycle. So that is rhythm period, calendar period, we have understood it. The second, we have seen basal body temperature, in which the female partner is measuring her temperature daily in the morning with a very accurate thermometer, the same thermometer daily. So the day she is ovulating on day 14, when the progesterone is coming, there's a little bit rise in temperature on that day. So if she is measuring daily, then only she will be able to pick up that small rise, that is 0.3 to 0.5 degrees Celsius. The third method I told you, billing method, that is cervical mucus method. That depends on the consistency of the cervical secretion, again of the female partner. So all these methods are depending on the female partner. But of all these, the failure rate is very, very high. The failure rate is very high. Now let's come on the fourth one. The fourth one is the sympathothermic method. So that is the combination of the first three. So if the couple is using individually calendar method, or individually basal body temperature method, or individually billing method, or cervical, so failure rates are very high. But if a couple is willing to combine the three, I mean the day on which the temperature is also raised, the day on which the cervical mucus also becomes stringy and profuse, and in the calendar also it is the unsafe period. So that is the highest probability the couple is in the unsafe period. So combining the three is sympathothermic. Sympathothermic is the combination of the three: basal body temperature, cervical mucus, and safe period. That is the combination of the three. So here failure rate is little bit less as compared to individual. You can understand it. Okay. So can we go ahead? Can we go ahead? How to check basal body temperature with the thermometer? No, I told you, no, Sutara, with the help of thermometer. So coming on the next method. So we have done the safe period, basal body temperature, cervical mucus method, and the combination of the three is sympathothermic method. Now the fifth method is abstinence. What is abstinence? It's complete absence of sexual intercourse. No sexual intercourse, no chance of conceiving, no pregnancy. So actually only method which is 100% effective. But it is not considered as a method of contraception because there is no sexual intercourse at all. Contraindication, premature ejaculation sometime can happen. Premature ejaculation is a contraindication of this also. So abstinence. Okay. The next is the coitus interruptus. What is coitus interruptus? It is the oldest method of voluntary fertility control. Here the male partner just before the ejaculation withdraws the penis from the vagina of the female partner. Again, failure rate is very, very high. It's nearly 25%. So coitus interruptus. And the last one is lactational amenorrhea method, LAM. Lactational amenorrhea method. What do you mean by lactational amenorrhea method? Imagine a lady who was pregnant and she delivered the newborn just now. Okay, so today she delivered a newborn. So once she delivered the newborn, what she will do? She will breastfeed the newborn. So breastfeeding is very good for the baby. We know that. It's for the newborn. It's very nutritious. It's very good. Is it good for mother? Yes, it's good for mother also. Because she is lactating the baby, she is getting the contraception from that. So whenever she is lactating during that period, if she is not using any other method and she is performing the sexual intercourse with the husband, again, so here she cannot conceive. She cannot conceive if she is lactating the baby properly. So that is lactational amenorrhea method. That is LAM. So if it is possible only if the baby is on exclusive breastfeeding. That is every 2 hours or every 3 hours, she is doing breastfeeding. She is providing breastfeeding to the baby. So what is the mechanism? What is the mechanism of that? When the baby is sucking the nipple of the mother, you can see the baby is sucking the nipple of the mother. The signal goes in the brain of the mother. So that signal goes in the brain of the mother and there is prolactin released from the brain. From the pituitary, the prolactin releases there. And that will suppress the GnRH. You know, there is an axis in human body. So what is the axis? There is hypothalamus in the brain, then there is pituitary, and then there is various organs. So hypothalamus, pituitary, and there is ovary. Let's consider ovary. So let's write it here, ovary. So from the hypothalamus, GnRH is secreted. GnRH, gonadotropin releasing hormone. When it comes on the pituitary, it stimulates the pituitary. So from the pituitary, FSH and LH is secreted. FSH and LH. And this is going to the ovary via blood. And ovary will release the ova, estrogen and ova only if FSH and LH is coming. So now I'm saying the lady is breastfeeding. She is breastfeeding the newborn, the baby for the first 6 months, exclusive breastfeeding every 2 hours, every 3 hours. So this will give a negative signal to the hypothalamus. So hypothalamus will not secrete GnRH. So no FSH, no LH, no FSH, no LH, no ova. No ova means even if sexual intercourse takes place, so sperm alone cannot produce the pregnancy. So sperm is present, but ova is absent now. So pregnancy cannot occur, conceiving cannot occur. So it is a very good method of contraception. So it is a natural method of contraception. How many of you got it? How many of you got it? Okay. So intense sucking of the breast it will lead to prolactin release. It will disrupt the secretion of GnRH, no GnRH, no FSH, no LH, no follicular development, no ova, and ovulatory cycle, no menstruation, no ova, and that will provide the contraception. How many of you got it? This is the mechanism. But it is possible. It is having 3 conditions. Number 1, the baby should be exclusively breastfeeding, because if the mother is giving some other food to the baby, so baby may not be very hungry every time, and breastfeeding will reduce. If the breastfeeding will reduce, maybe a little bit of GnRH is secreted and the ovulation takes place. And the baby should be less than 6 months. And there is amenorrhea. The female is not menstruating for the 6 months after pregnancy. So if these 3 conditions are fulfilled, the LAM is a very good method. Lactational amenorrhea method. Failure rate is 5 per 100 women here. So it's less. It's not very high failure rate. So that is lactational amenorrhea. So we are done with the 7 natural methods. How many of you got it? Give me a thumbs up. How many of you got it? Say yes. How many of you got it? Any problem? Any confusion till now? Can we go ahead? So the natural methods are done. We have seen the 7 natural methods. So if it is coming as a long question, you can write it, or if MCQs are asked, you can crack it. So let's solve some MCQs based on the natural methods and then come on the next method, that is barrier method. So we will be discussing the various barrier method in detail. Okay, so let's start it. Okay, so first question is in front of you. Can you please answer it? What is false regarding the calendar method of contraception? Can you read the 4 options? I'm asking the question based on the calendar method, the rhythm method, the safe period. Can you read the option and tell me what is false regarding that? Abstinence is required only for few days of the month. Is it true or is it false? Associated with no cost. There is no cost in that. Is it true or false? I guess this one is true. Yes, there is no cost in that. The couple have to just do the calculation. Safe period can be observed using the temperature method and cervical. So we can combine the 3, the calendar method with the temperature method with the cervical. So it will be sympathothermic method. Yes, this is also true. So you know the failure rate will be less, and ectopic pregnancy is a rare complication. Yes, I forgot to tell you, but ectopic pregnancy is a rare complication of this method. So what is false? The first thing is false. Yes, you all are right. No, A is false. So abstinence is not required only for few days. Abstinence is required for long period of the month. If the female is having irregular cycle, just suppose the female is having short cycle as 25 days instead of 28, and the longer is 35 instead of 28. So can you do the calculations? Please do the calculation. What is the formula? Shortest minus 18 to longest minus 10. Can we do it? Can you do it? So what is shortest? 25 minus 18 to what is longest? 35 minus 10. Can you do the calculation? So answer is 7, I guess. 2, you can see 25. So from day 7 to day 25, no sexual intercourse is allowed. So it's a very long period of the day. Abstinence is not required for few days. It is most of the month. So the sexual intercourse is allowed only after day 25 or before day 7. Okay, so that is the thing. So here abstinence is required for, but ectopic pregnancy is a rare reported complication of these methods. So you can learn that. How many of you got it? Can we go ahead? So coming on the next question. The next question is in front of you. Which of the following natural method of contraceptive is most effective? So I told you 7 method. You tell me which is most effective. Calendar method or billing method or sympathothermic method or basal body temperature method. The question is very easy. If you know what is sympathothermic method, you can answer it. I guess you know the sympathothermic method is the combination of the 3. So it combines the calendar method with billing method with basal body method. Okay, basal body temperature. So combination of the 3 is sympatho. So here the failure rate is very less, and that's why among the natural, this is the most effective. So among these options, yes, you all are right. Absolutely right. So correct answer here is C, and you all are right. So let's move on the next method. So out of all these methods, we have started spacing methods. That is temporary suppression of fertility. It's not permanent vanishing of the fertility. It is temporary suppression. So we have seen the 7 natural methods, and we have seen the MCQs based on them. Now I'm coming on the barrier methods, the barrier methods of the contraception. Can I start the barrier methods? Let's start the barrier methods. There are 2 types of barrier methods, physical and chemical. What do you mean by barrier method? Now please understand, this is female reproductive tract. I guess everyone can understand this. These are the ovaries you can see here. From the ovaries, ovulation takes place. So this is the ova. So every month, one ova is released from the Graafian follicle. One of the follicle mature. The mature follicle is Graafian follicle. So alternately, so right ovary and left ovary, 2 ovaries are there. Alternately, 1 month ovulation takes place from the right, 1 month ovulation takes place from the left. Almost alternately it happens. But 1 month, usually 1 ova. Exceptions are there, but usually one ova is released. The ova which is released is picked by the fallopian tube. From the fallopian tube, it will go here, 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 here. It will be there in the uterus, in the fundus of the uterus, it will be there. And if the sexual intercourse is taking place during the same period, so sperms are entering from here, and the ova and the sperm fertilize with each other, and the zygote will be formed, that is pregnancy is occurring, and they are conceiving, the couple is conceiving. So by barrier method, we are stopping the meeting of the ova with the sperm by various methods. So that is the meaning of the barrier. We are providing a barrier between the ova and the sperm. So that is the barrier. So two type of barrier methods are there: physical barrier and chemical barrier. So let's start with physical methods first. First we will discuss physical methods, then we will come on chemical methods. So physical methods, we are having 4 physical methods. The condom. If I say condom, I mean the conventional male condom. If we have to mention the female condom, yes, female condoms are also available. So we have to separately write it's a female condom. So male condom, female condom, diaphragm and vaginal sponge. So out of which the male partner, for the male partner only male condom is there. The remaining 3 are for female partner. The remaining 3 are for female partner. Okay. So these are the 4 physical methods available for the couple. So any one of them can be opted by the couple. So being a doctor, you should give the cocktail choice to all the contraceptive to the couple, whichever is convenient to them, they can pick. So you have to provide a cocktail of choices. Got it? So if a couple is coming to you, being a doctor, that you are a doctor, and you have to give the contraceptive advice to that couple, so you have to understand the history and everything, the various diseases they are having, and based on that you have to provide all the offers, all the cocktail of offers. So we will see the details of all the physical methods one by one. Can we start? Can we start? So let's start with the male condom. Let's start with the male condom. Condom means male condom. It is the most widely used method throughout the world as well as in India. And this is a device which is worn by the male. In India, the trade name is Nirod, and it is provided free of cost by the government of India. Okay, so free of cost it is provided under the by the government of India. So you can see it prevents the semen from being deposited, of course, on the vagina. So that is the male condom. What are the advantages? Advantages: they are easily available, they are safe, they are inexpensive, easy to use, do not require any medical supervision, no side effects, light, compact, disposable, and the most important advantage, they provide the contraception. They are used for contraception, they are providing that, but additionally they are preventing the STDs also, like gonorrhea, trichomonas, moniliasis, non-gonococcal urethritis, herpes, chlamydia and HIV. So that is the biggest advantage. Apart from contraception, the big advantage is that on which you get the question. And condom reduces the chances of cervical dysplasia and the cervix cancer of the female partner. Because if the couple is using the male condom, the male is using the condom, so HPV infection of the female partner will be reduced. And cervical dysplasia and cervical cancer, the biggest risk factor is the HPV. This is the reason. So these are the advantages. How many of you got it? So that is the advantages. Coming on the disadvantages, there is only one disadvantage. It can lead to contact dermatitis to the female partner. So that is the one disadvantage. So there are many disadvantages, but only one disadvantage. As I told you, the Nirod is supplied by the government of India free of cost under family planning clinics. It is available free of cost at family planning clinics in India. The trade name is Nirod in India. Okay. So that is the male condom we have seen. Now we are coming on the female condom. In the female condom, it is a device which is used by the female partner during the sexual intercourse, as the name indicate. It is also known as reality condom. It is also known as female shield or fam shield. It is also known. So learn the other names: fam shield or reality condom. So it is the female partner which is using. It was invented by Danish MD Leze Hazel. It is the name of the scientist, the person who discovered it. It is worn internally by the receptive partner or the female partner. It is having 2 rings, the internal ring and the external ring. And it is worn by the female herself just before the sexual intercourse, and it has to be put in the cervix, you can see. So it is having 2 rings in contrast to the male condom. So looking at the image, you must be able to identify, is it a male condom or female condom. Male condom have only 1 ring, you can see. The female condom have 2 rings, the internal ring and the external ring. You must understand that the internal ring is put on the, it covers the cervix and it has to be put on the internal os here, and the external ring is outside the vagina, So you have to see where is internal ring, where is external ring. It is pre-lubricated already with the silicone, and spermicidal jelly is not to be used separately. It already contained that. So that is the female condom. I hope you got it. What is female condom? Say yes if you got it. Got it? So that is the female condom. Okay. So here the two rings are there. Okay. So the question comes on the one ring and two ring as the MCQ frequently in your exam. What are the advantages? It is reusable. In contrast to male condom is not reusable, but female condom can be reused. It prevents pregnancy. Okay, it is a contraceptive device, but along with preventing the pregnancy, it also prevents STD like the male condoms. So the advantage of the female condom is the use is depend on the will of the female partner, and it does not require the male cooperation. The female partner herself, she can choose and she can use it, and it prevents STD and HIV. Okay, so the differences between male and female condom you usually get in your exam as a question, either as a short question if you're preparing for university exam, or it can come in the form of the MCQs also. So male condom is made up of latex usually, and female condom is made up of polyurethane or nitrile. Here failure rate is low, relatively low, but here failure rate is relatively high. We measure the failure rate with the help of Pearl index. What is Pearl index? I will let you know at the end. Okay. Here number of rings is only 1. Here number of rings is 2. You get MCQ on that. This one is not reusable, the male one, but the female one is reusable. Okay. So these are the important questions. Both of them prevent pregnancy and both of them prevent STDs. So contraception is provided by both of them, and STD prevention, HIV prevention by both of them. Compatible with oil-based lubricants? No, but this one is yes. Okay, so that is the thing. So you got it. I guess we have done the two types of condom, male condom and female condom. Any confusion? Can we go ahead? Any confusion? We have go ahead. I have already mentioned the side effects or adverse effect. Nawaz, go back and see. Anything else? Anything else? Can we go ahead? Yes. So let's come on the third thing, the diaphragm. Let's come on the third thing, the diaphragm. The diaphragm is also worn by the female partner, the receptive partner, the female partner. Diaphragm, also known as Dutch cap. It is a vaginal barrier. It has to be inserted in the vagina by the female partner just before the sexual intercourse. You can see it here. It is worn by the female partner. It is inserted by the female partner into the vagina so that it is preventing, it is making a barrier. So during sexual intercourse, the sperms are entering here, but they cannot cross it and they cannot reach in the fundus of the uterus. They cannot meet the ova. So they are providing a barrier method. So diaphragm is inserted just before the sexual intercourse and must remain in the place during sexual intercourse, but immediately after sexual intercourse, it should be removed, or maximum within 6 hours, after 6 hours of the sexual intercourse. If it is placed there only, after sexual intercourse also, if it is there in the vagina, it can cause toxic shock syndrome to the female. So the only side effect is the toxic shock syndrome if the female forgot to take it out after sexual intercourse and it is placed there only for the 24 hours or more than 24 hours. So maximum within 6 hours, it's safe to use. After sexual intercourse, it should be worn just before the sexual intercourse. So that is the thing. The disadvantage, it increases the risk of UTI in the female, yeast infection, bacterial vaginosis, and if left in situ for more than 24 hours after sexual intercourse, it can lead to toxic shock syndrome. So that is the side effect you can see. What are the contraindication of the diaphragm? Diaphragm should not be used in a female who is having prolapse, rectocele, because for the diaphragm, the vaginal muscle should be tight so that it can be inserted there. If the vagina is loose, so the diaphragm cannot be placed properly in the vagina. It cannot be placed there. It will be loose there. So if the female is having prolapse or cystocele or rectocele or retroversion or any fistula is there, it cannot be placed there. If the female already have UTI, it again increases the risk of UTI. So that is the thing. And it do not provide protection against STDs. So if a female is having multiple sexual partners, like a prostitute is there, this is not a good contraception for them. So coming on the next one, vaginal sponge. The vaginal sponge. So let's come on the vaginal sponge. It's the sponge-like thing. Again, it has to be worn. It is marketed under the name of the Today. The trade name is Today. It is sponge. The size is 5 into 2.5 centimeter. You can see it's a sponge like thing. It is saturated with 1 gram of nanoxanol 9. What is nanoxanol 9? Nanoxanol 9 is a chemical that kills the sperm. Sperm. So if it is worn by the female partner here just before the sexual intercourse and she is performing sexual intercourse, so the sperms are entering inside. The number one, it is providing the barrier. The sperm cannot cross it. By chance, if the sperms are crossing it, it contains nanoxanil inside that. So nanoxanil 9 will kill the sperm. So it is physical as well as chemical double barrier. You got my point? The sponge is soaked in. The sponge is already soaked in nanoxanol 9. What is nanoxanol 9? I told you it is spermicidal. It kills the sperm. It's a chemical that kills the sperm. So this is the reproductive tract of a female. You can see this is vagina. if ovulation is taking place, ova is there, and during sexual intercourse she is using the vaginal sponge. So she is wearing the vaginal sponge and putting it in the vagina just before the sexual intercourse. So during sexual intercourse, if the sperms try to enter in the female reproductive tract, they cannot enter because it is providing a barrier. If they try to penetrate it, it contains the nonoxynol 9 that kills the sperm. So it is providing physical as well as chemical double barrier. That is the question. It has to be inserted vagina just prior to the sexual intercourse, and it must be placed there only as high in the vagina. Okay, and it has to be used only once. It is not reusable. It has to be wet a little bit before insertion so that proper insertion is there. And it cannot be left in place again for more than 6 hours like the this one only, that is diaphragm. If the diaphragm as well as vaginal sponge, if any of them is left after sexual intercourse for more than 24 hours, they cause toxic shock syndrome. So they are worn just before the sexual intercourse and removed within 6 hours after the sexual intercourse. If they are placed more, the chances of toxic shock syndrome are there. So that is the disadvantage in them. So what are the disadvantages of vaginal sponge? Allergy can be there to some female, vaginal dryness, vaginal soreness, vaginal itching can be there. They do not give protection to STDs. So not advisable for a female who is having multiple sexual partners. They are not providing the protection for HIV. Okay, it can lead to toxic shock syndrome if left for more than 24 hours after sexual intercourse. It can increases the risk of fungal infections and UTI. How many of you got it? How many of you got it? Can we go ahead? Okay. Okay, so can we go ahead? One by one, we will discuss all. Nawaz, listen to the session completely, then ask this question. Okay. What else? Can we go ahead? Yes, microbiology sessions, they are already available on Cerebellum. What else? Anything? Any other confusion or doubt you are having? So we are done with the physical methods. In the chemical methods, I already told you the name of the chemical. What's the name of the chemical that kills the sperm? Only one chemical, nonoxynol 9. It's a chemical. It's a chemical that kills sperm. It's spermicidal. How it kills sperm? It is a surface active agent. It attaches with the sperm. This chemical attaches with the sperm and inhibit the oxygen uptake in the sperm. So sperm get killed. So learn the mechanism also. First learn the name of the chemical. The name of the chemical is nonoxynol 9. What does it do? It kills sperm. But how? It is a surface acting agent. So this is a sperm. So this nonoxynol 9 bind with the sperm. It is a surface acting agent and it inhibits the oxygen uptake of the sperm. So sperm get killed. It's a spermicidal. Learn the mechanism. And it has to be put by the female partner by filling it in a syringe, an empty syringe, without a needle. So she is taking, the female partner can take a syringe and she can fill the syringe with this chemical. The syringe do not have the needle and she can insert it herself into the vagina just before the sexual intercourse. So that is available in the form of the jellies. So that is the chemical methods. So we are done with the physical and chemical methods. Say yes if you got it. Say yes. Safe period issue. I told you the formula of the safe period. Safe period is both before and after. So there is no formula for safe period. For unsafe period, the formula is shortest cycle minus 18 to longest cycle minus 10. Before that and after that is safe period. So safe period is before that also, after that also. But the unsafe period is this one. I hope you got it. Inshu, can we go ahead? Okay. Yes, definitely I will cover other subjects also. Definitely one by one, we will cover. Okay. So read the question and tell me the answer. Read the question. Barrier methods are all except. Tell me which of the following is not a barrier method. I told you the barrier methods. I told you the 4 physical barrier and 1 chemical barrier. So tell me which of the following is not a barrier method. Diaphragm, yes or no? Foam tablets, yes or no? Vaginal sponge, yes or no? And Lippes loop. Which of the following is not a barrier method? Can you write down your answer in the comment box, please? Lippes loop is one of the IUCD. It's not barrier. Yes, answer is Lippes loop. By foam tablet, we mean the vaginal sponge. It is the other name given to vaginal sponge. So diaphragm is there, sponge is there. Sponge is sponge only, no? And vaginal sponge, it is the other name given to that. So Lippes loop is not a method. It is one of the intrauterine device, intrauterine contraceptive device, IUCD. So correct answer is D. Yes, absolutely right. I will tell you what is Lippes loop on IUCD. So coming on, one more question for you. Today is a contraceptive device which contain what? Today. So first you should know what is today. So today is the trade name given to what? It is a trade name given to vaginal sponge. It is soaked in what? What does it contain? Does it contain prostaglandin F2? Does it contain norethistron? Does it contain 9 9, or is it a copper releasing mesh? What is it today? So I told you today is the name given to sponge, the vaginal sponge, and it contains the spermicidal. Absolutely right. Absolutely right. So correct answer is C. It contains nanoxanol 9. Very correct. So we are done till now. What I taught you, I'm teaching you the contraceptive methods. So there are 4 spacing method and 2 terminal. We will see all of them today only one by one at one place at one shot. Okay. So we have already covered the natural methods. I taught you the 7 natural methods of contraception. You get many questions on them. Believe me. The second, we have seen the barrier method, the most widely used method in India as well as in the world. So here I taught you 4 physical and 1 chemical. Total 5 barrier methods I told you. Now I am starting with IUCD. What is intrauterine contraceptive device? IUCD. Intrauterine contraceptive devices, IUCDs. What are IUCDs? So let's start IUCDs. They are available in the form of the T. They are like this. They have a horizontal stem and they have a vertical stem. So they have horizontal and vertical. They are in the form of the letter T, and they are inserted inside the uterus of the female. The female cannot insert it herself. A trained doctor, MBBS gynecologist is required to insert it. So she takes the help of the gynecologist, and the gynecologist will insert it. The doctor will insert it. She cannot insert it alone by herself like the sponge and the diaphragm. No, it's a device which has to be inserted by a trained personnel. Okay, so it's a device. It's a long-acting device that will be reversible once removed, and it has to be placed inside the uterus, not in vagina, not in cervix. It's like this. It is having 2 threads at the bottom. Can you see the 2 threads here? The 2 threads are there, and it has to be placed inside the uterus. You can see like this. I will tell you the mechanism of action also. It's like this. It's compressible. It's like this, and it is having the 2 tails. The threads are known as tails. The 2 tails. Why 2 tails are provided? So once it is inserted inside the uterus, the tails will be here, the tails. So tails will indicate that it is properly inserted, and whenever the lady is using the washroom, she should be willing to check the tails all the time. So she will be assured that the device is it in place. So sometimes what happens, spontaneous expulsion occurs. Spontaneous expulsion, and she can, or sometimes perforation occur. So in both the cases, either it is coming out spontaneously or it is going perforating and going inside. So at that time, the tail cannot be traced by the female. She cannot see the tail. She should report it immediately to the doctor. So if you're a doctor and you are a gynecologist, you are inserting the IUCD in any of the female, you should warn her that daily she should check the tails. That is the threads which are coming out of the vagina. So while using a washroom, she can do that. And if any time the tail is missing, she should report immediately. There can be expulsion. So the unwanted pregnancy can be there, and there can be perforation. If it is perforation, it will be severe painful. So that can be the thing. So that is the thing. Now you can see here, it is inserted like this. So we can insert it like this in various positions. So I'm not going in the detail how it is inserted step by step. For inserting, we require a device that is inserter. So both the vertical limbs are closed like this on a horizontal stem like this. It is inserted inside, and then we take out the inserter. Once we take out the inserter, the vertical limbs will be open like this. Inside the uterus, it will be like this. Inside the uterus, it will open like this. So once we are inserting, it is in closed situation like this, and after going inside, it will open like this in the uterus. So that is the thing. How many of you got it? Okay, so let's go ahead. Yes, I will start other subjects also. So here I have started teaching PSM. Okay, so let's go ahead. So how many types of IUCDs are there? First, you tell me how many types of intrauterine contraceptive devices are there. There are 2 types. Non-medicated, which are known as first generation. They don't contain anything. And the medicated one. The medicated one contains something, the second generation and the third generation. The second generation contain copper in them, and the third generation contains hormones in them. So they are medicated. They contain some bioactive material in that, either copper or hormones. The second generation contain copper, and the third generation contain the hormone, and first generation don't contain anything. They are non-medicated, so they are known as first generation. So total 3 generations are there. I will come on the details of all 3 generations one by one. These are the types. Before that, let me tell you, whenever we talk about any of the IUCD, there is a number written on that, like copper T7, copper T220, copper T380. What does that number represent? For example, copper T220, copper T380, it is written like that. So you may be thinking, ma'am, what does that number represent? So all the IUCDs have certain number written on that. And what is that number representing? So it is the surface area of the copper on that device. It is in millimeter square. So if it is 220, the 220 millimeter square copper is wrapped on that. I will show you. Can you see here the copper wrapping is there. So if you measure the surface area of this copper wiring on that, it will be of that number. It can be 220, it can be 380, it can be 7. It is in millimeter square, not centimeter. It's millimeter square. So it's an MCQ which is asked in your exam. So crystal clear concept. The number represents the surface area of the copper in copper T devices. Number 1. Number 2, there are 4 sizes available, A, B, C, D. So different females have different size of the uterus. So the females can have small uterus, some females can have large uterus. Now sonography should be performed before inserting it. So a gynecologist should perform the sonography, or a radiologist should perform the sonography and have a look on the size of the uterus. So from female to female, the size can vary. So 4 sizes are available. A, B, C, D, the letter represent the size. A is the smallest available, and the D is the largest one. So judge the size of the uterus of that particular female in which you are going, being a doctor, you are going to insert the IUCD, and you decide the size for that. Now, if the size of the uterus is small and you are inserting a big one, the perfo can occur. You are inserting a big one like this. So perforation can occur. You can see the perforation. So judging the size is very important. And if the size is big and you are inserting a small one, so it will not be holding there properly, and spontaneously it will expel out. So the size is important, and 4 sizes are available. I repeat, A, B, C, D. A is the smallest one, D is the largest one. So the letters represent the size. So we have numbers, we have letters. Numbers represent the surface area of the copper. It's a MCQ. And the letters represent the size. The 4 sizes are available depending on the uterus size. Depending on the lady to lady, we can differ it. Okay. Now the next, either AG. Sometimes AG is written. What is AG? AG is the chemical formula for silver. And AU is the chemical formula for gold. I guess you know that. Okay. So it can contain gold or silver inside that, along with the copper, a little bit of gold and silver along with copper. So AG or AU is mentioned on that. Okay. So either the numbers are mentioned. So what does numbers represent? Or the letters are present. What does the letters represent? Letters are 4, A, B, C, D. Number can be any, or AG or AU will be written. What does that represent? So these all are your MCQs. The number represents the surface area of the copper. The letters ABCD represent the size, and the AG/AU is representing the gold or copper which contain. Okay. Yes, copper T contains copper, absolutely. Absolutely. Okay. So let's come on that. I'm coming on that, the classification. Wait. Okay. So there are 3 generations. Let's come on. What are the 3 types of IUCD? The 3 generations of IUCD. First generation, second generation, third generation. What do you mean by that? First generation is non-medicated. It don't contain anything. No medication is added. Only 2 examples are there. Lippes loop and Grafenberg ring. Only 2 examples are there. Lippes loop and Grafenberg ring. It don't contain anything. Let me show you. You can see it here. Just a second. This one is Lippes loop. It don't contain, neither it contain copper, no additional copper, nor it contain any hormone. Okay, so these are non-medicated, you can see. And second and third generation are medicated. So what does they contain? The second generation contain copper. So second generations are known as copper T because they contain copper in them. And they have some number, copper T7, copper T220, copper T380, copper T AG. So you know what does they represent. Okay, third generation contains hormones in them. So again in the third, so second generation are many. Third generation are only 2. They contain hormone. One is progesterone and one is LNG. Progesterone and LNG. LNG is also known as Mirena. So progesterone and Mirena. These are the 2 examples of third generation. And 2 examples of first generation, that is Lippes loop and Grafenberg. Remaining all are second generation. That is copper T. They are many. So copper T, only simple copper T, copper T220, 200B, 200C, Nova T, multiload 325, multiload 250, copper T380A, 380AG. So multiple forms are available. So tell me the classification. How many type of IUCDs are available? Can you tell me how many type of IUCDs are available? Yes, there are 3 generations. First generation, second generation, and third generation. Can you tell me the meaning of that? Yes, the first generation is non-medicated. It don't contain anything. Second generation is medicated. It contains copper. And third generation is also medicated. It contains hormones. Got it. Okay. Now you tell me the examples. So we have 2 examples in the first, 2 examples in the second, and multiple examples in the second. So I want you to learn 2 here and 2 here. Can you please tell me what are the 2 examples in the first generation? It's Lippes loop and Grafenberg ring. We don't use them. They are first generation, they have very high failure rate and very high side effects. So we don't use them nowadays. But nowadays we have better options available. So best is the third generation. Okay, second and third generation both are good, but third are the best one. So third generation, we are having two options. They contain the hormones inside them. Which hormones they have? What are the examples? One is progesterone and one is Mirena. Mirena is also known as LNG20. How many of you got it? Can we go ahead? Say yes. So please learn the classification. You can see copper T contain the copper wrapping on that. Okay, so here you can see this one contains the hormone, the third generation. It contains hormone inside that, and little bit of hormone is released daily. So there is a fixed amount of hormone. That particular milligram is present of that particular hormone inside that, and it will be released daily a little bit. So in the next 2 years, 1 year, 2 year, 3 year, it will be completely depleted, and after that it has to be replaced. So it has to be taken out and another one has to be inserted if the female want to continue it. Okay, so there is a shelf life. So based on how much hormone is present inside that. Okay, and copper contain the copper wiring on that. So this is third generation, this is second generation. First generation we don't use. So here in the examples, you can see in the diagrams, you can see this one is first generation. These two are third generation. See the third generation, progesterone and LNG, that is Levonorgestrel, or also known as Mirena. This one also known as Mirena. And remaining all are second generation. So second generations are many. Okay. Got it? I'm coming on that. Wait, let me finish the topic. I'm coming. How long protected? I'm coming. What is the mechanism of action of IUCD? How they give contraception? What is the mechanism of action? Can you tell me? What is the mechanism of action? Yes? Can you tell me the first generation, the second generation and third generation? So basically inside the uterus, when we are placing the copper T in a female, that is acting as a foreign particle. And they will do certain changes in the endometrium of the uterus and making it unfavorable for implantation. So if ovulation is taking place and here is the ova, and during the ovulation, if the sexual intercourse also takes place and here is the sperm, and if the sperm is meeting with the ova and the zygote is formed, they are not preventing ovulation. They are not providing any barrier to the sperm. Sperm ova can meet and they can form a zygote, but zygote cannot be implanted. The implantation is inhibited because the endometrium is unfavorable for implantation. That is the main mechanism. So they don't inhibit ovulation. Ovulation takes place. In contrast to OCP, which I'm going to teach you the next. In OCPs, oral contraceptive pills, the ovulation will be inhibited. Here, no inhibition of ovulation. Ovulation takes place regularly every month, every 28 days. Like the day 14, and there is no barrier method provided. So the ova and the sperm can meet, they can form a zygote, but the point is that zygote cannot be implanted. So if the zygote is formed, okay, I got it, but it cannot be implanted. Since it cannot be implanted, so contraception is there, pregnancy cannot be there. How many of you got it? Yes, I will provide the annotated PDF also. Okay, yes. So can we go ahead? At the end of the session, I will provide you the notes. Can we go ahead? So that is the mechanism of action, the main mechanism of action. It inhibits implantation. Now someone was asking now how long protection? That depends on the shelf life of different IUCDs. Different IUCDs have different shelf life. These are in years. After these many of years, it has to be replaced. If any of the copper IUCD is used, 3 to 5 years. So 3 to 5 years, it has to be replaced. So that shelf life is 3 to 5 years. So tell me the two one of the copper T, one of the second generation copper T, special copper T, that is copper T380A, A is Ag, containing silver. So it's very costly because it contains silver along with the copper. So it's costly, but the shelf life is 10 years. So once it is inserted, for 10 years, nothing has to be done. And after 10 years, it has to be changed. So it is having the longest shelf life, and you get question on that. What about the two third generation IUCDs? What are the two third generation? One is progesterone, so shelf life is only 1 year. And one is LNG. So here also the shelf life is 7 to 10 years. So you have to learn the main shelf life. So what is the shelf life of important one? Tell me for most of the copper T, what is the shelf life? One of the special copper T, that is copper T380A or Ag. What is the shelf life? And tell me the two third generation. What are the two third generation? One is progesterone, and one is LNG. Tell me the shelf life of these. So you frequently get question of these four. Don't learn all, learn these four. So for most of the copper T, it's 3 to 5 years. But one of the special copper T containing silver, it's 10 year. It is having the highest shelf life. Progesterone is very good. No side effect, hardly any side effect. But shelf life is only 1 year. So every 1 year it has to be replaced. Okay. And LNG, it is again having the shelf life 7 to 10 years. You get questions on that. Okay. Okay, can we go ahead? I'm coming on the criteria, Sagar. Criteria, I will tell you side effect, the criteria of IUCD insertion. Okay. Now coming on the side effects. What are the side effects of IUCD insertion? What are the side effects? There are five side effects. What are those? Tell me the most common, second most common. Most common side effect is bleeding. After insertion, the female complain of bleeding for the next 15 days, 20 days, maybe a month or two. But bleeding stops spontaneously, so there is a little bit of spotting, maybe continued for 1 or 2 months. But if the bleeding is not severe, don't bother. Don't take it out. Just reassure the lady that it will go away by itself. Don't worry. So that is bleeding, the most common side effect. But sometimes it can be severe bleeding, bothersome. You can give the iron tablets, and if it is very severe, then only remove it. Otherwise, don't remove it. The second most common side effect is pain. The lady can have pain after insertion. So this is the uterus of the lady, and being a doctor, the gynecologist, you have inserted, for example, the doctor have inserted the copper T inside the lady like this. So the pain can be there because it is imposed on the walls. The pressure is there on the walls of the uterus, and sometimes the pain can be there. So pain is the second, and sensitivity of different females can be different. So second most common side effect is pain. So just pain will subside automatically after 1 month, 1 to 2 months. Just if the pain is very severe, you can prescribe certain painkillers, certain NSAIDs, but don't remove it. But sometimes the pain is very severe and the lady cannot bear it. Now, when it will happen? When the size of the uterus is less and the IUCD insert is very big one. So the big IUCD is inserting very much pressure on the walls, and it can produce the severe, or sometimes the perfo can be there. Okay, so that in that case the removal is required. So most common cause of removal is pain. So 2 MCQs are there. Tell me the most common side effect of IUCD. What is the answer? And tell me the most common side effect of IUCD for which removal is required. So this is second question. So tell me the answer of both. Most common side effect is bleeding, but for bleeding removal is not required. Lady can bear the bleeding. It is a minute spotting or bleeding. Okay. But most common side effect for which the removal is warranted, the removal is required, that is pain. That is pain. Most of the time pain is also bearable, but sometimes it is unbearable. Say yes. Got it? So please learn that. So you get 2 MCQs on this. So third side effect is PID, that is pelvic inflammatory diseases. Fourth is perfo, and fifth is spontaneous expulsion. We will see the details of all 5 and move ahead. So most common side effect is bleeding, as I told you, most common for 1 to 2 months, and it will do not require any medication, and it will go by itself. Maximum bleeding takes place with first generation. That's why we don't use them nowadays. The non-medicated one, we don't use them. Second most common side effect is severe pelvic pain. Second most, but this is the most common side effect which require removal. Most common side effect which require removal. But usually it will disappear by its own by 2 to 3. But sometimes if it is very severe, like in case of incorrect placement of IUCD in the uterus, the size is disproportionate, and the perfo is there, or certain infection happens while inserting, you have not taken care of the septic precautions, and infection is occurring, so the pain can be severe. In that case, you have to remove it. Okay. Management of the pain: if it is slight, give analgesic. If it is intolerable, remove it and advise some other contraceptive. Okay. The third is PID, that is pelvic inflammatory diseases, PID. So infection can occur in the tubes, in the ovaries, in the connective tissue, in the peritoneum, pelvic peritoneum. And if the female is already having the PID, so risk increases by 2 to 8 times after IUCD insertion. The organisms which are causing the infection is Gardnerella, anaerobic streptococcus, bacteroids, coliform, and actinomycetes. These are the bacteria which causes PID after IUCD insertion. Sometimes perfo is there, although rare of the rarest, but perfo, especially the perfo, can occur in anteverted or retroverted uterus. Now just suppose you are a doctor and inserting the IUCD in a lady. See, this is how you are inserting. So you can do a perfo if it is anteverted or retroverted. So perfo is very common in such uterus. So that's why doing a sonography before inserting is very necessary to avoid the perfo. But if perfo is there, the lady will have severe pain, and within 48 hours, it will be visible on the X-ray, pelvic X-ray, and you have to remove it as soon as possible. So remove the IUCD as soon as possible after perfo. Okay, so that is the thing. Spontaneous expulsion, sometimes it comes out of its own. Again, the biggest reason is disparity. The uterus is very big, and the IUCD which is inserted is small size. So it can come out. Spontaneous expulsion can occur within the first few weeks or during menstruation. During menstruation, the canal widen. So at that time also, spontaneous expulsions are common. Okay. So how uterus size is determined? It is determined by a trained gynecologist or a doctor by performing pelvic sonography, ultrasonography, based on which the uterus size is performed, and there will be a judgment by the doctor that which of the IUCDs fit in which lady based on the size. The 4 sizes are available. Got it, Amar? Can we go ahead? Now tell me some MCQs based on the side effect. I told you the 5 side effects. Can you enumerate what are the 5 side effects? The most common side effect is bleeding, I told you. The second most common side effect is pain, I told you, but it is the most common side effect which require removal. The third is PID. The fourth is perfo. And the fifth is spontaneous expulsion. Now, I will ask you the question. Tell me highest pregnancy rate and lowest pregnancy rate in which IUCD? Highest pregnancy rate and lowest. Even after inserting the IUCD, the female can become pregnant, rare of the rarest. Now, there is a lady in which I am a gynecologist, for example, and I have inserted an IUCD. Okay, now the lady is sure that she will not become pregnant, and the lady has performed the sexual intercourse with the male partner, and after that she become pregnant. It can happen. It can happen. Failure rate is there in all contraceptive. Apart and unless and apart, it is sterilization. So all the contraceptive devices have some failure rate. Some have more, some have less. So here the efficacy is 99%, but 1% failure rate is still there. So still the lady can have pregnant. Okay, so that is known as unplanned pregnancy, So it is the failure. It is due to the failure of that contraception, failure of IUCD. So in which IUCD it is highest and in which it is lowest? So in first generation, it is highest. That's why we don't use it nowadays. Lippes loop. It is highest failure rate. We don't use it nowadays. And lowest is in the third generation. One of the third generation, that is LNG. So LNG is the best one because here the shelf life is also 7 to 10 years, if you remember. It has to be replaced after 7 to 10 years, and pregnancy rate is the lowest. So once you have inserted in the lady, then you can assure the lady the efficacy is 99.9%. Although 0.1% is still there chance. We cannot be 100%. But efficacy is very high. Efficacy is very high. Okay. Now highest expulsion and lowest expulsion. Expulsion means spontaneous expulsion. Without doing anything, sometimes it can spontaneously come out. So again, highest is in Lippes loop. First generation, we don't use it. And lowest is in progesterone, which is one of the third generation. Lowest expulsion. And highest removal, lowest removal. Removal is due to pain. So highest pain is in LNG. LNG, although very good, it is having lowest pregnancy rate, but highest removal, it causes pain. But lowest removal pain is progesterone. So all the IUCDs have its own pros and cons. Some have shelf life more, but other side effect is more, like that. So whatever question is there, you have to give answer based on that question. Okay. So 3 type of side effects you have to learn. Pregnancy rate, highest and lowest. Spontaneous expulsion, highest and lowest, and removal due to pain, highest and lowest. Highest, lowest, highest, lowest, highest, lowest. You have to learn the questions and answers like that. Okay. Tell me highest pregnancy rate, it is in Lippes loop. Highest expulsion, it is also Lippes loop. But highest pain or highest removal is progesterone. Got it? Now tell me the lowest one. The lowest are better one. So lowest pregnancy rate is in progesterone. Lowest expulsion also progesterone, but it is having highest removal although. And lowest removal requires LNG. So you have to tell all this to the couple that there is nothing 100%. So some side effects are there in all of them. Although the third generations also have some or other side effect. Can we go ahead? So that is the thing. Now someone was asking the ideal candidate for IUCD insertion. Ideal candidate. So the female should have at least 1 children before you insert it. You cannot insert it in nullipara. No. At least 1 child should be there to that lady. Okay. It should be done in the lady should be in one relationship. It should not be inserted in prostitutes or the ladies or the females who have multiple sexual partners, because the chances of PID or STD will be high in that case. So we cannot do that. So the lady should be in mutual monogamous one relationship. And there is no history of previous PID, because IUCD will further exaggerate it. And choose not to use the hormonal contraceptive. If the lady is using IUCD, she should not be used the OCPs or other hormonal contraceptives. So these are the 4 criteria based on which we will select the ideal candidate. So that is the thing. Now tell me the contraindications. You get many MCQs on contraindication, believe me. Now my advice, don't learn the relative contraindication. Otherwise you will become confused. Learn absolute contraindication. So I am a doctor and any lady is coming to me, doctor, I want contraception, and she's selecting IUCD as her choice. We have to give choice. We cannot impose anything that you have to use this. We have to give all the cocktail choice. The natural methods are there, but failure rate is very high. The barrier methods are there. So as and when required during sexual intercourse, at the time of sexual intercourse, only the barrier methods are used. Apart from that, IUCDs are there, OCPs are there, and permanent methods are there. So she can select, the couple can mutually select what is the best contraceptive for them. Okay. If they are selecting IUCD, so first I have to look for all these. If this is absent, then only I can go for that. If any of them is present, I cannot use IUCD in such females. Number one, if the female, so I'm having a mnemonic also. The mnemonic is please don't try to put condom. It's a mnemonic. You can make some other mnemonic also. P stand for puberal sepsis. If the lady is having puberal sepsis, we cannot insert IUCD. So for example, now there is a lady, there is a female who is pregnant. Now she is in labor and she's delivering a newborn. She has delivered a newborn. Okay. And she's in hospital. She's in hospital. She has done the hospital delivery and the newborn is absolutely healthy. Now, before discharge from the hospital, she's already in hospital now and she has completed her family. This is the third newborn she gave birth and she has completed. She don't want more children now. The couple do not want. So before getting discharged in the puberal period only, she want the gynecologist or the obstetrician to insert IUCD. So sometimes the ladies come from periphery, from the villages, and it is not advisable to insert IUCD just in puberal period, because uterus, the walls are very weak just after the delivery. But if it is inapproachable, you see the ladies coming from some periphery, you can do that also. But here, if the lady is in sepsis, the puberal sepsis, you cannot do that. So it is a contraindication during pregnancy. Obviously during pregnancy we cannot insert it, obviously. So in the pregnancy, uterus contains the fetus. So we cannot insert the IUCD in the uterus during pregnancy. So P stand for two things, puberal sepsis and pregnancy. D stand for DUB. Okay, that is the uterine bleeding. So dysregulated uterine bleeding is there. T is for trophoblastic disease. P is for PID. And C is for cancer, two cancers, cervix cancer and endometrial cancer. So please don't try to put condom. Put condom. You can make some other mnemonic also. That's a mnemonic. Learn the 5 contraindication during which IUCD cannot be used. The absolute contraindication. P for pregnancy as well as puberal sepsis as well as PID. 3 P are there. Okay. D for DUB. T for trophoblastic disease and 2 cancers during cervix cancer and endometrial cancer. If it is a cervix cancer or uterus cancer, you cannot insert IUCD. So that is the absolute contraindication. Read relative contraindication by yourself. No need to learn. You have just a look on them. Okay. Now what's the best timing of IUCD insertion? For example, a female is coming to me. The age of the lady, for example, is 35 years or 30 years. She already have 1 children. Okay. She already have 1 child, and for the next 4-5 years, she has just delivered 6 months back, and for the next 4-5 years she do not want another child and she wants spacing. She do not want the permanent sterilization and she is opting IUCD. So when should I call her? During her menstrual cycle from day 1 to day 28. Which day should I call her and give her appointment and insert the IUCD? Which is the best day? So does it depend on the menstrual cycle? Yes, the timings depend on the menstrual cycle. So according to you, what is the best timing? You tell me. In the menstrual cycle of a lady from day 1 to day 28, if we consider an ideal menstrual cycle, what is the best timing of insertion? When we should insert the IUCD with highest success rate? What is the best timing? And tell me the reason also. Yes, can you tell me? The reason? Yes. So what is the best timing? The best timing is within day 1 to day 10. When the lady is menstruating, the best time is menstruating. You will say, ma'am, why? Why during menstruation is the best time to insert the IUCD? Why during menstruation you want to insert it? Because if the lady is menstruating, I'm sure she is not pregnant. If the lady is menstruating, I'm damn sure she is not pregnant. So because whenever I'm inserting the IUCD, I should be sure that she is not pregnant. So I will ask a leading question, are you pregnant? Just suppose she's saying, no, doctor, I'm not pregnant. But maybe she do not know and she is pregnant. Maybe. So last month she was having menstruation, but this month the menstruation is due and she has not overcome that date. So the first symptom of pregnancy when the lady come to know she is pregnant is absence of menstruation, of that amenorrhea. Okay. So if the lady is menstruating, I will be sure that she is not pregnant. That's why I want to insert during menstruation only. Number 1. And number 2, during menstruation, the cervical canal is widened, a little bit widened. So insertion is relatively easy. Insertion is easy during that time. So these are the two reasons. The cervical canal is widened and least chances of pregnancy because she is menstruating. So best is to insert during menstruation or within first 10 days. Within first 10 days. So that is the question which you get MCQ in your exam. So that is the best timing. Got it? Now read the question. Tell me the answer. We are done with the IUCDs. Now we will come on hormonal contraceptives. Read the question and tell me the answer. Copper T 380A. What does 380 represent? 380 is a number. What does it represent? Does it represent the number of turns of copper wire, or it represents the surface area of copper wire in millimeter square, or it represents the surface area? Here the surface area of copper T was there, or it is the surface area of the copper in millimeter square, or it is the effective life of the copper T in quartons. What is the correct answer? I told you, no? What is the correct answer? Can you please tell me the correct answer? Yes, absolutely right. Absolutely right, Ankan, Garima. The correct answer is surface area. I guess you are getting confused. Surface area of the copper, not the copper T. Surface area of only copper wrapped on that, not the complete T. Now this is the complete copper T. C. The two options B and C. This is the complete copper T. I do not want the surface area of complete copper T. No, I want the surface area of the copper which is wrapped on that. So this number represents the surface area of the copper, not the complete copper T. So option B is not correct. Option C is correct. I hope you got it now. Someone was saying B also. No, B is not correct. The correct answer is C. Coming on the next question, tell me the most common side effect of IUCD. Read the question properly. Is it pain? Is it bleeding? Is it pelvic infection or ectopic pregnancy? Now tell me the correct answer. What is the correct answer? You give the answer, I will have a sip of water meanwhile. Yes. So what is the correct answer? Yes, absolutely right. Most common side effect is bleeding. But if I change, yes, the correct answer is bleeding. But if I change the question, most common side effect require removal. What is your answer now? Require removal. What is your answer now? Would you like to change your answer? You should change your answer now. Yes, in that case, the answer will be B. So pain is the most common. Now, the next question is that only. So the most common side effect of IUCD which require its removal. The same four options are there, likewise. The same four options. But this time the answer will be pain. Okay, so these two questions are very frequently asked in your exam. One more question. What is the characteristic of an ideal candidate for copper T insertion includes all of the following except. I told you the characteristic, the criteria. It has born at least one child. Is it a criteria or not a criteria? Willing to check the tail daily while using the washroom. Is it a criteria or not a criteria? Have a history of ectopic pregnancy and have normal menstrual period. What is not a criteria? So I guess I told you the lady should have at least one child. Then only you will be able to insert it. In a nullipara, it is contraindicated. Willing to check the tail. If she is not willing to check the tail daily, you cannot insert it. Sometimes it can do the spontaneous expulsion or perfo, and regular menstrual period. This is the criteria. But if she is having a history of ectopic pregnancy, it is a relative contraindication. I told you the relative contraindication. No, in the relative contraindication, if she is having a history of ectopic pregnancy, it will be a relative contraindication. Got it? So history of ectopic pregnancy is a contraindication. It is not an indication. Coming on the next question, copper T 380 IUCD is replaced in how many years? Copper T 380A. Every 4 year, every 6 year, every 8 year, or every 10 year. They want to ask you the shelf life. What is the shelf life? Shelf life of copper T 380 AU, which contains silver. What is the shelf life? Absolutely right. It is the copper T which is having the highest shelf life. I told you. So it has to be replaced every 10 years. Every 10 years. I told you the shelf life of all of them. Third generation IUCD. Which of them is third generation? Which of them is third generation? I told you IUCDs are of three types. First generation, second generation, and third generation. First generation are two. Lippes loop and Greffenberg ring. Third generation are also two. What are the two? Progesterone and LNG. LNG is also known as Mirena. LNG20. Second generation are all the copper Ts. Now have a look on the option. Mirena is one of the option. So Mirena is third generation. And remaining all the options which are given, copper T, copper T, copper T, they are second generation. I hope you all got it. Absolutely right. So you get very simple questions if you know that. Which of the following is the absolute contraindication of IUCD? I told you a mnemonic. Please don't try to put condom. That was the mnemonic. So these are the 5 absolute contraindication of IUCD. Does it contain anemia? No. Does it contain diabetes? D for not diabetes. D is DUB. It's not diabetes. No. Does it contain hemorrhage? No. But does it contain PID? Yes. One of the P is PID. I told you. One of the P is pregnancy and pubertal sepsis, and one is PID. The two cancers are there. C is cancer, cervix cancer, and endometrial cancer. T is trophoblastic disease. So learn the absolute contraindication at the tip of your tongue. Okay. So PID is the correct answer, I mean to say. Absolutely right. Absolutely right. So we are done with natural methods. Here I taught you the 7 natural methods. I taught you the barrier methods. I taught you 4 barrier methods: male condom, diaphragm, vaginal sponge, and female condom. Then we have done with the IUCDs. We have seen 3 types of IUCDs: first generation, second generation, third generation, their contraindications, their side effect, their timing of insertion, their composition, their mechanism of action, each and everything. Now, the last one I want to tell you is the hormonal one. Then after that, we will see the terminal methods also. So let's start the hormonal contraceptive. How many of you are with me? Give me a thumbs up with full energy. We will continue the hormonal contraceptive. So let's continue with the hormonal contraceptive. So hormonal contraceptives are of 2 types, oral and injectable. The oral one contain the pill. In the form of the pill, they are taken by the female partner daily. Okay, I will tell you how it, on which day it has to be started, for how many days it has to be taken, and it contains the hormones which suppresses the fertility temporarily. That is the hormonal contraception. What is the mechanism of action? I'm teaching you the oral one. Oral hormonal contraceptions, that is known as OCP. OCP pills. Oral contraceptive pills, which are taken orally by the female partner. It is in the form of the tablets, 1 tablet daily. So it contains total 21 tablets of same composition and 7 are iron. So total 30 tablets are there. You can see 28 tablets are there. I'm sorry. Total 28 tablets are there. So for the 4 weeks it is provided. The last one are just to complete the cycle. They contain iron. And the first 3 contains the hormones. The first 3 weeks tablets contains the hormone. What is the mechanism of action? How it provides contraception? What is the mechanism of action? Listen. I will show you the female reproductive tract here. You can see the female reproductive tract. Let me draw it once for you. There are 3 mechanisms of action of OCPs. I will show you all 3 here. Have a look. Please understand. How OCP provide contraception? You can see here, these are the ovaries, and this is the fallopian tube here. This is the fallopian tube here. Okay, listen. Now I told you every month ovulation takes place. Every 28 days ovulation takes place on the 14th day in a regular menstrual cycle. So ovulation 1 month it is taking from right ovary, 1 month it is taking from left ovary, alternate it is taking place. So just suppose, how does ovulation take place? How does ovulation take place? So I told you there is an axis in the female body. In every human being, there is hypothalamus, there is pituitary, and these are the ovaries. So let's draw the hypothalamus here. Let's draw the pituitary here, and this is the ovary you can see here. Okay, this is the axis. So from hypothalamus, GnRH is coming. GnRH. It will go and act on the pituitary. From the pituitary, LH and FSH occur. It is coming and it will act on the ovary. Then from the ovary, ova will be released. Ovulation will take place, ova will be released, and estrogen will also come. So from the ovary, number 1, ovulation take place. Number 2, estrogen and progesterone. Estrogen and progesterone are also released from the ovary. Okay, now listen. We are giving OCP to this lady. What is OCP? Oral contraceptive pill. So what basically we are doing? The lady is taking a pill daily. Daily she is taking. So what does that pill contain? That pill contains estrogen and progesterone. A fixed composition of estrogen and progesterone. Which estrogen, which progesterone, and how many milligram or gram, what is the amount, I will tell you. But it contains estrogen and progesterone. So listen, if estrogen and progesterone is high, it will give a negative feedback on the hypothalamus and the pituitary. Because it is high now, it will give negative feedback. So whenever the lady is taking daily OCP, daily B, so estrogen and progesterone in her blood will be high, always high throughout the cycle. So throughout the cycle, estrogen, progesterone high, it will give a negative feedback on the hypothalamus also, pituitary also. So GnRH will be less. LH and FSH will be less. If LH, FSH will be less, ovulation do not take place. If ovulation do not take place, ova will not go in the uterus, and how the conception will take place. How many of you got it? So this is the mechanism. The mechanism is, the main mechanism of OCP is this one. It inhibits ovulation. How does it inhibit ovulation? By giving negative feedback on the hypothalamus and the pituitary and suppressing the FSH and LH surge. No FSH, no LH, no LH surge, no ovulation. It suppresses ovulation. Now, this is the main mechanism. There are 2 backup mechanisms. Just suppose if the lady is taking OCP and by mistake ovulation occurs. So the ova is coming here. By mistake, if this one mechanism is not working, ovulation take place. What is the second backup? The second backup is that it thickens the cervical mucus. OCP thicken the cervical secretion, cervical mucus. Thickening of cervical mucus. So now if the sexual intercourse takes place also, sperm cannot penetrate this So sperm cannot penetrate and sperm cannot reach here. Sperm cannot reach here. This is the second backup mechanism. If by mistake ovulation taking place, there is a backup also. There is a backup also. There is a third backup also. If just suppose ovulation takes place and even after this ovulation take place, and if the cervical mucus is thickened and sperm still penetrate, and is reaching to the ova. You say, ma'am, now what? Now the fertilization will definitely take place. I agree. Fertilization will take place and the zygote will form. But OCP make the uterus, the endometrium, unfavorable for implantation. So although zygote is formed, it cannot be implanted. This is the third mechanism. So there is no chance the person, the female is taking OCP very regularly, every day, throughout with regularity. She is not missing the pills, so there is 99.9% chance the couple will not conceive, because there are three mechanisms. How many of you got all three? So these are the three mechanisms. You can see here, the sexual intercourse is taking place, the sperms are going. Even the sperms are going, you can see here ovulation do not take place. You can see the ova cannot come out. So main mechanism is inhibition of ovulation. How many of you got it? So there are three mechanisms. Number one, you can see the lady is taking the OCP. So estrogen and progesterone is inhibiting the hypothalamus as well as pituitary. No FSH, no LH, no ovulation. So first is inhibition of ovulation. If by mistake ovulation takes place, so cervical mucus is thickened. If that also the sperm penetrate, then it makes the uterus unfavorable for implantation. I hope you all got it. I'm trying very hard to explain you. So that is the three mechanism I told you. Now there are two types of OCPs, oral and injectable. Oral, let's start oral. I will teach you both oral as well as injectable. Let's start with oral OCPs. The oral OCPs. There are three types of oral OCPs: monophasic, biphasic, triphasic. What do you mean by monophasic, biphasic, triphasic? So total 28 pills are there. In monophasic, the first 3 weeks, the same pills are there. The same composition, same pills. The last week is always iron. It always iron. The last week. Total 28 pills are there. 1 to 7, first 7 days. Then 8 to 14, the second week, the next 7 days. Then 15 onwards till you can see here from the third week. I mean, this is the first week, this is the second week, this is the third week, and this is the fourth week. So you can see here it is 21, 7 to 14, here 14 to 21, and here 21 to 28. So if the first 3 weeks contain the same pill, it is monophasic. Biphasic, the first 10 days is one, and next 11 pills will be different. So total 21, and last is always iron. And in triphasic, first week, second week, third week, the pills will be different composition, I mean, and last is always iron. So in all of them, the last pills are always iron pills. So monophasic, biphasic, triphasic. Most common are monophasic. Monophasic are most commonly used two types, Mala D and Mala N. What is Mala N and Mala D? Both of them are monophasic. So throughout the 21 days, same composition pills are taken. What is Mala D and Mala N? These two are most commonly used pill in India, the monophasic pill. What do you mean by Mala D and Mala N? What is D and N? Achha, both of them contain estrogen? Yes. Both of them contain progesterone? Yes. Tell me which estrogen and which progesterone. So estrogen is always ethyl estradiol. Always. Estrogen is always ethyl estradiol. There is a third pill, Familon also. So Mala N, Mala D and Familon are the three most commonly used. Okay. So estrogen in all of them is ethyl estradiol. You can learn EE, ethyl estradiol. That is the estrogen. Okay. But progesterone is different. In Mala N, N stand for norgestrel. In Mala D, D stand for desogestrel. And in Familon also it's desogestrel. Now learn the composition. Estrogen is 0.03 milligram, and in Familon it's 0.02 milligram, because this is low dose. Estrogen causes side effects, so we realized it and we reduces its amount in the low dose one. And progesterone is 0.15, 0.15, 0.15 milligram. So please learn the composition of the three: Mala N, Mala D, and low dose OCP. I mean Familon. The low dose OCP, low estrogen containing OCP. So tell me the estrogen and the progesterone in each of them. First tell the name, then tell the amount. Estrogen is always ethyl estradiol. Very easy. Ethyl estradiol. Now learn the progesterone. Progesterone is also easy. N for N. That is norgestrel. D for D, that is desogestrel. In Familon also it's desogestrel. Now it's time to learn the amount. How much? How much? So here 0.03 milligram. Here also 0.03 milligram, and here we reduce it to 0.02 milligram instead of 3 because this one is low dose OCP, low dose estrogen OCP. This one is in milligram, all of them. Okay, and here always 0.15, 0.15, 0.5, 0.15. Always, they all are same. It's milligram. So they all are in milligram. So this is what you are asked in your vivas also. Please learn it by heart. That is the monophasic pills. How many of you got it? So out of the 3, the monophasic are most important. So here we provide first 3 weeks the same pill. So Mala D, the first 3 weeks, the female take ethyl estradiol plus desogestrel. Mala N, it is norgestrel. And Familon, you know that, the composition. And last week is iron. So total 28-day cycle. Okay. So that is the, what is the schedule? The lady has to start on day 5, the 5th day of menstruation. Okay. So from 5th day, start this. 5th day of menstruation. So 5, 6, 7, 8, 9, 10, 11. Day 11, the first row will be completed. From day 12 onwards, she start the next. 12, 13, 14, 15, 16, 17, 18. On day 18, she will complete. If she is taking regularly without missing. I will tell you what if she miss also. That is also a Viva question and MCQ. From day 19, she will start the third one. So 19, 20, 21, 22, 23, 24, 25. 25. Then leave it. Then leave it. From 26 onwards, these are the iron tablets. So during these days, she will menstruate. Definitely she will menstruate. During these days. Whenever she is menstruating, no pills are required. So there is a break of 7 days. There is a break of 7 days. During those 7 days, we are giving iron, not to miss the regularity. So during these 7 days, she will take the red tablets. The red tablets contain the iron. So from day 26 onwards, she will take the iron tablets. 26, 27, 28, 29, 30, 31. Likewise, she will take the iron. Okay, I mean 26, 27, 28. 28. And after that, again the first 1, 2, 3, 4. And the 5th day, again, she will start the next trip. So without any gap, she will start the next trip. So again, if it is a 28-day cycle, regular 28-day cycle, this is like that. So how many of you got it? This is the schedule. This is the schedule. So this is the schedule of OCP. Coming on the adverse effects. There are 5 types of adverse effects of OCP. What are the 5 types of adverse effects? Cardiovascular effect. These are due to estrogen component. OCP contain both estrogen and progesterone. So cardiovascular effects are due to estrogen. Initially, we used in Mala D and Mala N. We used to give 0.03 milligram estrogen. Then later on, we realized, though, no, estrogen is not very good because it is causing the cardiovascular side effects. So we reduce the amount. Nowadays, we give Familon and it contains low estrogen. Instead of 0.03, it contains 0.02. That is the reason. Metabolic side effects are due to progesterone. Okay, and there are certain general side effects. OCPs are carcinogenic if taken for a long duration, not for short duration. If the lady is taking OCP for the 5 years or 10 years, then the carcinogenesis, certain cancers can occur and others. So coming on one by one, cardiovascular side effects. What are the cardiovascular side effects? What are the cardiovascular side effects? So the lady can have MI, the female can have MI, cerebral thrombosis, the thrombus can be formed, venous thrombus can be formed, DVT can occur, and hypertension. So these are due to estrogen, and that's why we use low dose OCP which contain less estrogen, that is 0.02 milligram. At this dose, these side effects are very minimal. Very minimal. That is cardiovascular side effect. The metabolic side effects are due to progesterone component. So obesity can be there if taken for a too long time, and altered lipid profile can be there. Hyperglycemia can be there. So lady can become diabetic and the lipid profile can be altered and blood pressure can be more. Hypertension can be there. That is the metabolic side effect. General side effect, the lady can have breast tenderness, weight gain, as I told you, weight gain due to water retention, headache, migraine, and bleeding disturbances can be there. Carcinogenic, OCP increases the risk of two cancers, cervix cancer, breast cancer. So if any female having a family history of breast cancer, to the mother, to the sister, to anyone, don't give OCP to that. Okay. Or cervix cancer also, don't give OCP. Don't give OCP to such female. Okay. So it increases the risk of two cancer. Breast cancer and cervix cancer have taken too prolonged period, not for short period. Others, there are certain non-specific side effects like hepatocellular carcinoma, adenoma also. These are two malignant cancer. This one is benign cancer. It increases risk of one benign cancer also, that is liver adenoma, gallbladder disease, cholestatic jaundice, okay, vaginitis. These are non-specific ones. Okay. Coming on the beneficial effects of the OCP. OCP have beneficial effects also. So although it causes many side effects, I agree, but it is having a list of beneficial effects also. So it is useful in benign breast disorders. It is useful in PID. It is useful in dysmenorrhea, ectopic pregnancy, iron deficiency anemia, and benign ovarian disease, malignant ovarian disease, endometrial cancer, colon cancer. Now see what I'm telling you. It decreases the risk of these 3 cancer, and it increases the risk of these 2 cancer. So cancers and OCP. You know, this relationship is very tricky. You get MCQs on that. Tell me the 2 cancers, the OCP increases the risk. And tell me the 3 cancers, OCP reduces the risk. Can you tell me the names? What are the 2 cancers, OCP increases the risk? Carcinoma cervix and carcinoma breast. OCP increases the risk of these 2. And what are the 3 cancers, OCP reduces the risk? OCP reduces the risk of colon cancer, ovarian cancer, colon cancer, ovarian cancer, and endometrial cancer. That is uterus cancer. So please learn OCP and cancer. You get questions on that. Many MCQs come. This is a tricky area. Please learn that. Give me a thumbs up if you got it. So that is the thing. Okay, that is the beneficial. Now, absolute contraindication. Never give OCP to any lady having these conditions. Now, if a lady is coming to me and she wants contraception, the couple is coming and they want a contraceptive advice from you. You are a doctor. So you are offering all the cocktail, and from them easiest is OCP. Okay. So the couple is opting the OCP. So before prescribing OCP to any couple, to any female, to any lady, checklist. If the lady is having any of these, never give it. So I'm having a mnemonic for you. The mnemonic is: banks have various scheme to provide home loans during May. It's a mnemonic. It's a mnemonic. So B for breast cancer. If the lady is having breast cancer in the past or any family history of breast cancer, don't give OCP. First question asks, do you have breast cancer, or any of your relative have breast cancer? If she's saying no, then only prescribe. The second H stands for hypertriglyceridemia. Ask the lady to do a lipid profile. If she is having cholesterol high, triglyceride high, don't give, because OCP further exaggerated. V stands for vaginal bleeding. If she is having any kind of undiagnosed vaginal bleeding, it can be a cancer. Don't give it. So ask, do you have any undiagnosed bleeding? So if she's saying no, then only prescribe it. S stands for smoker. If the lady is more than 35 years and she is a smoker, don't give OCP. That will increase the risk of thrombosis and cardiovascular side effects. T stands for thrombophlebitis. The OCP further increases the thrombosis. P for pregnancy. Of course, you can't give it in pregnancy. Ask the lady, are you pregnant? Okay. H for hypertension. It further exaggerates the hypertension. L for liver dysfunction. D for diabetes. And M for migraine with aura. So it will further exaggerate all these conditions. So before prescribing OCP to any lady, ask. This is known as checklist. You are a doctor, you should know the checklist. Ask these leading questions. Do you have breast cancer? Do you have any lipid profile, altered lipid profile? Do you have vaginal bleeding? Are you a smoker? Are you pregnant? Do you have hypertension? Are you diabetic? Do you have migraine? If no, then only prescribe it. If any of them is yes, go for some other alternative. You can't give OCP. So that is the absolute contraindication. Relative contraindication, read yourself, but don't learn them. So you are going to get the question on absolute, not on the relative. Got it? Say yes. Say yes. Got it? So that is the thing. So OCP is a contraceptive of choice in newly married couples. In newly married couples which want to stay together, they are not in different cities, they are in the same city. So that is the best contraceptive in them, because it is easy to take. And the newly married couple, if you offer them the barrier method, maybe they do not know how to use it. The male partner, the female partner, they do not know how to use the condoms, diaphragm, sponge. So barrier failure rate is high because they are very new for that. Okay, but the OCP is the best contraceptive to offer them. After evacuation of molar pregnancy, it is the best contraceptive. If the woman wants the spacing between the pregnancy, it is the best contraceptive. And if there is a family of ovarian cancer, this one is the best contraceptive because it will have a double role. It will further reduce the risk of the ovarian cancer and it will provide contraception also. So here there is a double rule. You know, so these are the OCP is the best contraceptive in all these conditions. There is one more pill which is known as Saheli. It is marketed under the name of Saheli in India. I'm talking. Okay, it is known as Centchroman. It contains Centchroman. What is Centchroman? What is Centchroman? Centchroman contains ormeloxifene. It's a chemical. Actually, it is a non-steroidal oral contraceptive. It is marketed under the name Saheli. It was discovered by Central Drug Research, Lucknow, India. You get questions on all of that. It is one of the SERM. You know what is SERM? Have you read SERMs in pharmacology? It is selective estrogen receptor modulators. So by this mechanism, it causes the contraception. Okay. So now what is the biggest problem with OCP? Most of the females complain that we have to take OCP for 21 days. I mean, the last 7 are irons of 28 days, daily one pill. We forget sometimes. Sometimes there is an emergency and sometimes we just forget. And it's a mess taking a pill daily, 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 daily. Doctor, is it a pill that we have to take only once? We have to take once in a one. In every 28 days, we have to take only one pill. Is such pill available? So yes, it is under research. Once a pill. Once a pill means it is a long-acting pill. It contains a long-acting estrogen which contains cholesterol, but it is under research. It is not marketed yet. Here the pregnancy rate is too high, but it has to be taken once a month, not every day. Every 28 days. Every 28 days it has to be taken one. So it is not very commonly used. So now many couples say, why only female partner takes the pill? Why not male partner? Male partner can also take the pill now. Why it is only the female who is taking the pill in the couple? So is it some male pill available for contraception? Male pills, so yes. So male pills, once they were marketed, but they were withdrawn from the market. Let me tell you what is male pill. So there was a research in 1950, the male pill. So male pill works on 4 principles. Male pill contain a chemical. It contains gossipol. Gossipol alpha. It contains gossipol. So what does gossipol do? It prevents spermatogenesis in male. Sperm formation is inhibited. Like the female pill inhibit ovulation, the male pill inhibit spermatogenesis. It interferes with sperm storage, sperm maturation. It interferes with sperm transport in the vas deferens, and it affects the constituents of the seminal vesicle also, seminal fluid also. So by these 4 mechanisms, it provides contraception. Okay. So sperm during sexual intercourse, the sperm is not reaching to the ova because sperm is not forming. Spermatogenesis is interfered, and transport is interfered, sperm storage is interfered, and seminal vesicle fluid is also interfered. Okay, so it was a good initiative taken, gossipol, but it is withdrawn from the market because of 2 adverse effects. Number 1, gossipol was toxic. For many males, it causes many toxic effects. And number 2, it causes permanent azoospermia. So female pills are temporary, means the female is taking the pill, she is having the contraception, I mean the spacing. When she leaves, the couple can again reproduce. Okay, so it is not permanent. But here it is observed that in many males, in nearly 10% of the male, it is permanent azoospermia. So even on leaving, on withdrawing it, on leaving it, the male cannot regain the sperm formation again. So it is permanent azoospermia in 10% of the male. So it was a big side effect. It was a big side effect. Okay, so it is withdrawn from the market and it is not used. But male pill was marketed once. You should know that. And it comes as the MCQ. It contains gossipol. What does it contain? It contains gossipol. Okay. So can we go ahead? Can we go ahead? So there are various things. If it is, missed, how many pills are missed and which week pills are missed? Week 1, week 2, week 3 or week 4? Which week 1 is missed, week 2, week 3 or week 4? If week 1 is missed, take as soon as you remember, nothing else. If 1 or 2 pills are missed, take it as soon as possible. If more than 3 are missed, for the next 7 days, use condom if sexual intercourse has to be performed as a backup. So that is week 1. That is week 1. Okay. Week 1, or you can say week 2 also. Week 1 and week 2. But for the week 3, if someone have missed 1 or 2 or 3 pills, for if missed 3 or more pills, okay, then take the one as soon as possible you remember. Take the one as soon as possible, the lady remember, and take the others in this row one day, then start a new pack, throw the old one and use condom for the next. Okay, use condom for the next. And here if iron pills are missed, throw the packet and start the new packet. So there is a fixed protocol for that. So because we are explaining all this not to the medico, the couples who are coming to us, they are not medicos, they are laymen. So we have to explain them according to the week wise. If any of the pill from this week is missed, what you have to do. If any of the pill from this week you have to miss, what you have to do. If from this likewise. Okay, so the generalized instruction is that if you have missed any pill, take the pill as soon as you remember. Okay, and use the condom for the next 7 days as a backup if the ovulation have already taken place during the missed period. So that is the thing. That is the generalized instructions we will give. So let's come on the injectable now. Okay, can we go ahead? Let's come on the injectable. We are done with the oral formulation. Injectables are also available in the hormones. Injectables, these are known as depot formulation. 3 depot formulations are available: DMPA, NETEN, and DMPA subcutaneous. DMPA, what is DMPA? D is depot medoxyprogesterone acetate. Depot medoxyprogesterone acetate, DMPA. What is NETEN? NET is norethistron You can see it is norethistron. It is one of the progesterone. By the way, these contain only progesterone. They don't contain estrogen. They contain only progesterone as the injectable. So they has to be given every 3 months. So DMP injection has to be given every 3 months. And NET injection has to be given every 2 months. It is not daily. It is not monthly. Every 3 months or every 2 months. So you get questions on that. That's it. Okay. So let me tell you few newer contraceptives and after that terminal methods. Few newer contraceptives we are having Norplant. What is Norplant? Norplant is, can you see these? 1, 2, 3, 4, 5, 6. 6 Cialis capsules are there. Each of them contain 35 milligram of NLG. And they are implanted in the arm, on the inner side of the arm of the lady. It's like a surgery. It is implanted inside. So once it is implanted inside, they secrete a little amount of LNG daily in the blood. So she don't have to use any other contraception if she is willing to do this surgery. It is subcutaneous implantation is done. Subdermal implantation. So it's a newer contraceptive. So it is, very recently it is marketed. So it is a subdermal implant. So it is implanted in the female, in the inner side of the arm via surgery, and it is intradermal implantation. Okay, so that is Norplant. What is the mechanism of action? Again, it inhibits ovulation, like the OCPs only, the main mechanism. It will inhibit the GnRH secretion. No GnRH, no LH surge, no ovulation. Efficacy is 5 years. After 5 years, they has to be replaced or use some other contraception. So after 5 years, it will be ineffective. That is the thing. Okay, so these are the things. The newer one, okay, you can use. There is one more newer one contraception, that is Assure. What is Assure? It's a permanent sterilization procedure for the female. It is available in USA, not in India. You can see it's a micro insert which are placed in the fallopian tube via catheter. Again, a surgery is required. So a catheter is used via catheter. It's an implant which is placed in the fallopian tube. It is a micro insert which is placed in the. So we go from the vagina and we reach the cervix, we go in the uterus, and from uterus we go in the fallopian tube, and in the fallopian tube we just insert it. Once we place it, the device will do certain tissue reaction there, so fallopian tube will be automatically blocked. Once we insert it, it will be automatically blocked. Once the fallopian tube is blocked, there will be contraception. So that is there. There are certain transdermal patches available. Can you see the patch? It is like a sticker. It is just stick there anywhere, any part of the body on the female body, female partner. So these are transdermal patches. They has to be applied on the skin. They release the estrogen and progesterone hormone in the blood daily, a little bit amount daily, like the OCPs only, they release in the blood a little amount. They prevent the pregnancy. They contain the same composition, ethyl estradiol and norgestrel. You can see. So same composition as that of Mala. And so this is the contraceptive patch. So one patch has to be applied for 7 days. After 7 days, it has to be replaced. So 3 such patches are applied in succession. Then there is a break for the 4th. So first week, 1 patch. Second week, 1 patch. Third week, 1 patch. 4th week, no patch. Then again, during which she will have the menstruation. So instead of taking the pill daily, if she is forgetting, she is a working female, she is very busy, so she can use the patches. They are very costly, but if she can afford, she can use that. So these are the patches available. Mechanism of action is same like OCP. They inhibit GnRH. They inhibit ovulation. They inhibit LH surge. They inhibit ovulation. So they are the replacements of the OCP. Okay, so that is the thing. Okay, so you can see. So that's all about it. The newer devices we have discussed. What is the mechanism of action of OCP? Can you tell me? What is the main mechanism? There are 3 mechanisms, but you tell me the main mechanism. Does it prevent fertilization? Does it prevent the release of the ovum from the ovary? Does it prevent implantation of the fertilized ovum? Or does it reduce sperm motility? What is the correct answer? What is the correct answer? Yes. Can you tell me the correct answer quick? Yes, absolutely right. So main mechanism is to prevent the release of ovum from the ovary. As I told you, 3 answers are correct here. So OCPs do 3 things. You can see it here. So these are the ovaries, and this is hypothalamus, this is pituitary, and this is ovary. Okay, from the hypothalamus we know GnRH come, and from the pituitary LH and FSH come, and then from the ovary ova and estrogen and progesterone come. Okay, now the pills contain estrogen and progesterone. So estrogen and progesterone in the blood is always high, which will give a negative feedback here and here. So no GnRH, no LH surge, no ovulation. So it inhibits ovulation. As a backup, it thickens the cervical mucus so that sperm cannot penetrate it. Even if the sperm penetrated and ovulation also take place, then because of the fertilization, the zygote which is formed, it cannot be implanted. So it inhibits fertilization, I agree. and it prevent the implantation. I agree, but these are not the main mechanism. The main mechanism is this only. So still I will go with B. If B is not given, then I will go with other options. Okay, can you tell me Mala N, which is one of the oral contraceptive, differs from Mala D in terms of what? Mala N contains what? N for what? It contains norgestrol, it contains estradiol, it is sold under social marketing scheme, or it is supplied free of cost. So what is the difference between Mala N and Mala D? So I guess everyone knows. Okay, Mala N. I guess it is the N. Answer should be A. It is not D. It is the norgestrol. N for norgestrol, D for desogestrel. That is the main difference between them. Okay, so that is the thing we should, yeah. Can you tell me DMPA is used every how many months? It is an injectable contraceptive. So every how many months it is repeated? Every 3 weeks, 2 months, 3 months, or 2 years? So yes, absolutely correct. The correct answer is every 3 months. Okay. Now the last thing is about the emergency contraceptive. What is emergency contraceptive? Now, if there is a couple who has performed sexual intercourse that was unplanned, and during sexual intercourse, it was unprotected. They have not used any of the contraception. Like there is breakage or slipping of the condom. They forgot, the female partner forgot to take the OCP pills for prolong, or insert the diaphragm, or insert the vaginal sponge just before the sexual intercourse, or diaphragm slipped out of the place during sexual intercourse, or miscalculation of the safe days in the natural contraceptive methods, or failure to practice the coitus interruptus by any of these. So they do not want the contraception, but they have already performed the sexual intercourse. So that is, at that place, we require emergency contraception. So if such a couple is coming to you that doctor, last night we have performed sexual intercourse, but we do not want to conceive, and it was an unprotected sexual intercourse because of any of the reason, or maybe it is because of the rape or forceful vaginal sex. So what you will offer? So being a doctor, you can offer them emergency contraception. Emergency contraception is effective during the first 5 days, that is 120 hours of sexual intercourse, but best it will act within 72 hours of unprotected sexual intercourse. So the day they are performing sexual intercourse, the unprotected sexual intercourse, and they do not want contraception, within 72 hours, they should take the contraception. Within 72 hours, for the best effect within 72 hours. So that is emergency contraception. It is also known as emergency pill. Okay, so what are the various methods available? These all methods are available, but the best one, or the most commonly used, is levonorgestrel tablet, single levonorgestrel tablet containing 0.75 milligram. So this tablet is not available. Actually, each tablet containing 0.75 milligram is available. So 2 tablets are taken together. So total 1.5 milligram, single dose. If it is single dose, it should contain 1.5. If it is a 0.75 milligram tablet, ask them to take 2 tablets together. Ask the female partner to take the 2 tablets. So from the couple, ask the female partner to take 1.5 milligram of levonorgestrel at one time. So that is the best one available. Okay, most commonly used. I mean, not the best, but the most commonly used. Apart from that, Yuzpe method is there, in which OCPs with 50 microgram of ethyl estradiol, 2 tablets twice a day, 12 hours apart is taken. So normal OCP which she is taking, she can take that only, but 2 tablets at one time, 2 times in a day, 12 hours apart. Okay, which contains 50 milligram of ethyl estradiol. That has to be taken. Apart from that, mifepristone is available. Ulipristal is available. What is ulipristal? It is a synthetic progesterone receptor modulator. It is also available. IUCD insertion is the best one if the female is ready to do that. And Centchroman, that is Saheli, is also available. Okay, so if the female partner is ready, the best is the IUCD insertion after unprotected sexual intercourse if they want an emergency contraception. So if this couple is coming to you, you are a doctor or any gynecologist, and what is their problem? They have performed unprotected sexual intercourse and they do not want to conceive. So best I will offer them, go for IUCD. But IUCD insertion, the female should be ready and fit for that. She should already have 1 children, and the criteria she should be fitting. The second best among all these, the second best is ulipristal. And the third one is levonorgestrel. So most of them select levonorgestrel. So that is the thing. I mean, the best one is different. You can read it here where it is written. Oh, I forgot to write, I guess. Yeah. So best one is IUCD. Second best is ulipristal. And third one is LNG, but most commonly is NLG. So that is the thing. That is the thing. E-pill is provided free of cost by Government of India as the emergency contraceptive. So under family planning, it is provided free of cost. Okay, mechanism of action is same. It inhibits ovulation. the hormonal effect. Most common side effect is severe nausea and vomiting can occur. And there is no contraindication for emergency contraception. Okay, so that is a thing. So you can read the question. I guess question is very simple. Yuzpe and Lenzi method is used for what? It is emergency contraception with OCP, emergency contraception with IUCD, or sterilization with no scalpel technique, or evaluation of newer contraception. So just now I taught you it is one of the emergency contraception with OCP, in which the regular OCP, which contain 50 microgram of ethyl estradiol, we give 4 tablets in a day. 2 tablets plus 2 tablets 12 hours apart. So this method is known as Yuzpe method, but not commonly used. So we are done with all these, with the newer contraceptives, everyone. So finally, we have to see the terminal methods. A little bit about the terminal method. What do you mean by terminal method? We have 2 types of terminal method. The male terminal method, the female terminal method, that is male sterilization, female sterilization, vasectomy and tubectomy. So let's start the female sterilization, that is tubectomy, in which the fallopian tubes are clipped and they are obstructed. Okay, what is the criteria? Just suppose you are a doctor and a couple is coming to you and they want to go for tubectomy. What questions you will ask? Number 1, are you married? It should be performed only in married females, or ever married once upon a time and now they are divorced maybe, or now they are single, but they are married once in their life. So then only it has to be performed. It cannot be performed in unmarried female. Okay, legally. The age of the female should be 22 to 49. Before that and after that it is not performed. At least one child which is more than 1 year of age. At least one child, the age of the child is more than 1 year of age. No past history of sterilization of herself, of course, and the spouse. If the spouse have done the vasectomy and they are in a monogamous relationship, what is the need? So it is not required that both the partners should do sterilization. If one of them is doing it and if they are in monogamous relationship, there is no need for the other spouse. If the spouse has not done the vasectomy, then only you have to do the female partner the tubectomy. She is in sound mind. She is not looking very depressed. Okay, and she is not psycho problem. Okay, so she is sound mind. She is not mentally ill. And that is certified by the psychiatrist. If it is mentally ill, it should be certified by the psychiatrist. If it is mentally ill, in that case, the statement is taken by the legal guardian or the spouse. Otherwise, it is the wish of the female. But if she is having some problem, some psychological problem, in that case, the spouse can take the decision or the legal guardian can take the decision of the tubectomy. In that case only. Otherwise, it is the decision of the female only. That is the criteria for female sterilization. So there are 2 types of surgeries, mini laparoscopy and laparoscopy. Mini lap and lap, 2 types of surgery. Either way, here we will go with the mini lap and lap. The techniques are different, but ultimately we are doing the clamping and clipping of the fallopian tube. We are obstructing the fallopian tube. So ovulation, although taking place every month, the ova cannot reach the uterus. Both the fallopian tubes are obstructed and clipped. You can see they are cut here, they are obstructed and clipped and clamped, so that ova is not coming. What about the male sterilization? The same criteria. Male should be married or ever married and less than 60 years. More than 60 years, we don't perform. At least one child who is more than 1 year. No past history of sterilization or of the spouse. Sound mind. For mentally ill, again psychiatrist certification, and in that case the decision will be of the spouse. That is vasectomy. The service here also 2 types of vasectomies are there. Conventional vasectomy and no scalpel. Nowadays we are performing no scalpel where no sutures are applied. Here vast difference is cut and clamped. There we are cutting and clamping the fallopian tube. Here we are cutting and clamping the vast difference. So we are obstructing the way of the sperms. The sperms are formed in the testes. They will go in the epididymis, but from the vast difference cannot reach in the urethra and they cannot be ejected. So that is the mechanism behind that. So we are done with that. I guess we are done with all the things. Now you have to learn what is the best contraception. Okay. What is the most common contraception used by the couples in India? Most common contraception. It is the barrier method. One of the 4 barrier methods. Condom, male condom, female condom, diaphragm and vaginal sponge. Among them, the male condom is most commonly used contraception in the world as well as in India. So it's an MCQ. Now let me ask you 2 questions. What is the best contraception for the couples who are staying apart and they occasionally meet and perform sexual intercourse? Or what is the best contraceptive advice you will advise to a newly married couple? Or you tell me these 2 answers. So if the couples are staying in 2 different cities and occasionally they meet and perform sexual intercourse, in that case barrier method is the best method for them. Okay. And if it is a newly married couple, OCPs are the best. Safest one is the barrier method. They don't have any side effect. Only at the time of the sexual intercourse, they are applied. And in HIV, the best method is IUCD plus barrier. That is the best in HIV. So these all are your MCQs. How many of you got it? These all are your MCQs. Read the question, tell me the answer. Tell me an ideal contraceptive for a couple who are living in 2 different cities and meets very occasionally. Just now I told you the answer. Is it barrier, OCP, IUCD, or injection DMPA? What's the correct answer? Just now I told you, the couple, the male and female partner are staying in 2 different cities and occasionally they are meeting. Yes, in that case, what is the correct answer? Barrier method. And if I change the question, if I ask you they are newly married and living together only, in that case, answer will become OCP. So we can change the question 2 times. So that's all about it. I guess we are done. Just a second. So if you want the notes of this topic, just a second. So if you have any queries on this topic or whatever topic I have taught you on YouTube in pathology, pharmacology, microbiology, PSM, or in medicine, if you have any doubt, you can ask your doubt on this contact number. You can note down this. It is only for chat support. Kindly don't call. Don't call. You will not be answered on call. So it is only by chat support. I personally respond on this number. So it's 9833032948. So if you have any query related to your studies or on these subjects or whatever topic I'm teaching you, you can text it. If there is any topic in your mind and you want me to take that topic on the YouTube, you can text that topic also. If many students are demanding the same topic, we can schedule it soon. Okay. If you want the notes of this topic, let me finish the session. Let me end the session. After that, in the same session, in the YouTube link, once you will open it, in the comment box, you will find the link. You will have to click on the link and you will be able to download the notes of this session. And all my YouTube session notes are available. They are free of cost. Okay. Here is a QR code provided to you. You can scan it if you wish. By scanning it, you will be diverted towards my website, that is MedLive by Dr. Priyanka, where you can connect with me on various social media platforms, that is Instagram, WhatsApp groups, Telegram, where I share very important, high-yielding educational content required for the medical students exclusively. So if you want to that, and it's absolutely everything is free. If you want to connect, you can do so, and you can take a snapshot. You can later on connect with me. So that's all about it. Thank you so much for your time, for your attention. So we plan the sessions based on the demand of the students. So today we have covered the topic complete contraception. I have already covered complete leukemias that's available. Now the next topic is hypersensitivity. After that, complete pharmacokinetics in one shot. After that, triage. After that, complete mycology in one shot of microbiology. After that, thalassemia. These are the topics we have selected for this month, that is February. If you have any topic in your mind, please text it. We will schedule it next month. Thank you so much. Bye-bye. Good night and all the best. Thank you so much. Thank you so much. Best of luck. Bye-bye. I'm just ending the session. And thank you so much for your precious time and efforts you are putting here. I'm very happy that looking at the response of the students till late night, you all are live and supporting me. Thank you so much. Thank you.